delegates who have taken their precious time out on this Saturday evening and come here for this wonderful event. I'm Sandeepan Mandal from Emcure Pharmaceuticals, and I welcome you all for this second APNIE conference, which is on management of pediatric vasculitis. And this is the 5th annual conference of the Association of Pediatric Nephrology of Eastern India and the 2nd National Pediatric Renal Rheumatology Update. We have very eminent international and national faculties who are pediatric nephrologists and rheumatologists who would be sharing their wisdom on how to manage this pediatric vasculitis. And without taking much time, I would hand over the session to an eminent nephrologist from our country, Dr. Subal Pradhan sir from Cuttack Medical College, Bhubaneswar. Over to you, sir, and welcome to the session.
Thank you, Mr. Sandeepan. Good evening to all. A very warm welcome, Dr. Tulas, Dr. Oni, Dr. Smith, of course, Dr. Kopo did not join, Dr. Susan Uttaff, Dr. Pankaj Hari, all the national faculties, esteemed viewers who have joined us today to be part of this 5th annual meeting of Association of Pediatric Nephrologists of Eastern India and 2nd Pediatric Renal Rheumatology Update. The concept of formation of Juvenile Pediatric Nephrology Society was initiated in 2017 with its first annual meeting at Guwahati, Assam in India, with handful of members to resume the dissemination of basic pediatric nephrology to the medical professions dealing with children, even the remotest area of Eastern India. We hope APNIE will provide a right platform for education, training, and collaborative research along with the mission of Indian Society of Pediatric Nephrology, International Society of Pediatric Nephrology, International Society of Nephrology in the field of pediatric nephrology. I thank all the faculties and look forward to listen to you all. Before we get started, I would like to introduce and welcome Dr. Susan Uttaff, the President of Indian Society of Pediatric Nephrology. Currently, she is the professor and head of the Department of Pediatric Nephrology, Thiruvananthapuram, Kerala, and request her to say a few words. Over to you, Dr. Uttaff.
Thank you, Dr. Subal, for the kind words. Good evening, ladies and gentlemen. I'm extremely happy to be with you all in the capacity of the National President of Indian Society of Pediatric Nephrology. Though virtual, we are all sharing this together in this on this August occasion. We are all aware that this era is witnessing the evolution of pediatric super specialties into independent services all over the country, akin to what was happening in adult medicine in 70s and 80s. It is a pleasure to witness the growth of pediatric nephrology and rheumatology in the country, though we know that we are lagging behind the Western countries and Western centers in actually delivering the state-of-the-art best now. 20 years back, there were only a handful of experts in these fields, but now we are seeing the tremendous development in cities at least. Dynamic, enthusiastic, young clinicians are delivering state-of-the-art care to children with chronic diseases affecting the immunologic and renal systems. However, we need to dissipate the knowledge far and wide as the care is lacking in many parts of the country. We all know that caring children with these diseases is never a solo, not even a duet, but comprehensive, coordinated.
I'm sorry to interrupt you, but your slides are not visible.
Not having any slides.
Oh, okay, ma'am. Sorry. Continue. Sorry.
Far and wide, as the care is lacking in many parts of the country. We all know that caring children with these diseases is never a solo, not even a duet, but comprehensive, coordinated, conscious effort from the clinicians across the specialties is required for optimizing the outcome. The second national update on the management of pediatric vasculitis by the Association Advancing Pediatric Kidney Care in Eastern India in collaboration with the rheumatology group is timely in view of the explosion of knowledge in the field of immunology and renal medicine that is happening in recent years. Introduction of new molecules in the therapeutic armamentarium, translating from bench to bedside, has revolutionized the management of diseases, especially vasculitis. I congratulate Dr. Subal Pradhan, Dr. Himesh Berman, Dr. Sinha, and the entire team for this novel venture in dissipating knowledge and helping the clinicians across the country, as well as the practitioners and budding residents and clinicians to improve the care of children with vasculitis. I wish this conference all success. Thank you once again.
Thank you, Dr. Uttaff. Now, without further ado, I request Dr. Himesh Berman, Secretary APNIE, to introduce the moderators. Dr. Himesh.
Good evening, everyone. So it is my pleasure to welcome and introduce three eminent academicians to as moderators of this session. First of all, I would like to introduce Dr. Gel Toulouse. Dr. Toulouse is a pediatric nephrologist in Great Ormond Street Hospital, United Kingdom. Sir has published more than 290 peer-reviewed papers, reviews, and book chapters. His research interests are inflammatory kidney disease, including lupus and renal vasculitis, hypertension, and urinary tract infection. Then we have with us Dr. Pankaj Hari. Sir is Professor of Pediatric Nephrology at All India Institute of Medical Sciences, New Delhi. Sir has more than 100 publications and has served as counselor for IPNA is serving as counselor for IPNA for 2020 to 25. Sir is Vice Chair, IPNA Best Practices and Standard Committee. Sir is the Chair, Academic Committee 2020 to 2024 of Indian Society of Pediatric Nephrology and Chair Working Group of ISPN Guidelines on Urinary Tract Infection and VUR. Sir has received FIAP in 2015, and Sir has served as President and Secretary of ISPN in the 2014 to 15 and 2001 to 2009 respectively. Next, we have with us Dr. Suma Balan. Madam is a consultant pediatrician and pediatric nephrologist. Madam has completed her undergraduate from JIPMER and postgraduate also from JIPMER. Then Madam has obtained MRCP from UK and CSST from UK. Her areas of interest are juvenile idiopathic arthritis, juvenile SLE, and regional pain syndromes in childhood. She has presented and published in International Pediatric Rheumatology and Nephrology Conference and is an active member of Pediatric Rheumatology faculty in India. I welcome all three of you, Dr. Toulouse, Dr. Hari, and Madam. Now it's over to you to conduct the session.
It's my privilege to introduce the chairpersons for the first session of the meeting. I would like to introduce Dr. Sushmita Banerjee, who's a pediatric nephrologist at CMRI and ICH hospitals in Kolkata, India. She's a member of the editorial board, Pediatric Nephrology Journal, 2014 to 2022. She's the president of the West Bengal Academy of Pediatrics, counselor for India, executive council of the International Pediatric Nephrology Association, previously national chairperson of International Pediatric Nephrology Group, author of several index publications in both journals and book chapters, and peer reviewer of national and international journal publications. And then I would like to introduce to you Dr. Nagraj, who is a very good personal friend and colleague who works as a pediatric nephrologist, pediatric rheumatologist in TRACC Bangalore. Nagraj, after his MD Pediatrics, has done a DNB in rheumatology and resettled in Bangalore. He's an academic, dynamic, and a very enthusiastic member of the Pediatric Rheumatology Association in India. And the next person I would like to introduce you to is Dr. Sana Jahan. She's a pediatric nephrologist in Pratiksha Hospital, Guwahati, India. She's presently practicing as a pediatric nephrologist in Renal Clinic and Pratiksha Hospital, Guwahati. She's done her MD Pediatrics in 2009 in AMC Dibrugarh, and followed by a fellowship in pediatric nephrology in CMC Vellore. And she has special interest in childhood nephrotic syndrome, urinary tract abnormalities, pediatric CKD, and RRT. Welcome to all the chairpersons.
So good evening. Should we start straight away? And if Dr. Pankaj Hari could share his slides. I don't think I need to introduce Dr. Pankaj Hari again. He has already been introduced by Himesh. He is very well known to the audience here. He has led in the Indian sphere in forming guidelines, in forming registries, and in many academic activities indeed. I think we all know about his academic prowesses, but what many of you may not know is what we have learned over the years is that Pankaj is also an ace badminton player. And I think it is this probably that he brings with him, because of this, that he brings with him a spirit of straightforwardness and sportsmanship in both academic and non-academic activities that he participates in. So Pankaj, I invite you to start your talk, Clinical Approach to Vasculitis in Children. Dr. Pankaj Hari.
Thank you very much, Shushmita. And the first time I'm hearing this kind of an introduction where you brought out the sportsman qualities of mine. Thank you very much again. So I'm going to speak on clinical approach to vasculitis in children. And I would like to thank the organizers of this symposia for inviting me to deliver this lecture. So this is the overview of my talk. I will be talking about the signs and symptoms of pediatric vasculitis. How does one evaluate a child who has vasculitis, and then a bit of classification of vasculitis. And then the next half of my talk would focus on ANCA vasculitis. I know that, in fact, large vessel vasculitis or Takayasu arthritis has been covered, and IgA vasculitis is also covered as two separate standout lectures in this update. So I would like to speak about ANCA vasculitis, this classification, diagnosis, the treatment guidelines, particularly the KDIGO, the new KDIGO guidelines on both induction as well as the maintenance. So are my slides moving?
Yes, sir.
Yes, they are fine.
Thank you. So systemic vasculitis is a complex disorder which affects almost all parts of the body and can result in significant morbidity and mortality even in children. The incidence, annual incidence in children is estimated to be about 23 per 1 lakh child population from US. And this is much more common in adults, which is twice the incidence that is seen in children. However, there are certain vasculitic disorders which are more common in pediatrics, but the one IgA vasculitis and the Kawasaki disease, which are predominantly disorders of childhood. So this disorder is the vasculitis is characterized by inflammation of the vessel wall, infiltration by neutrophils, and sometimes eosinophils and other cells, which results in vessel wall necrosis and results in various kind of manifestations. So about the recent advances that have happened in pediatric vasculitis, while a lot of work has been done in adult vasculitis, and as far as therapies are concerned, we are almost dependent on the trials that happen in adult vasculitis for formulating our own treatment protocols. However, there's been effort in classifying pediatric vasculitis, particularly Kawasaki disease and IgA vasculitis, and also the pediatric vasculitis activity scores as well as damage indices have been also developed. So when does one suspect vasculitis in a child? Generally, there can be systemic symptoms in the form of fever, weight loss, fatigue. It could involve, depending on the organ affected, if it affects the central nervous system, it can present as stroke, cranial nerve palsy, mononeuritis multiplex. It could involve the upper airway, resulting in epistaxis, septal perforation. In the lungs, the manifestations could be in the form of hemoptysis, asthma, tracheal stenosis, Large vessel vasculitis, when they could present with severe hypertension, absent pulses, discrepant blood pressures, bruit and claudication. It could also affect the musculoskeletal system. It can affect particularly the small vessel vasculitis can affect the kidneys and the skin in the form of renal manifestations could be hypertension, hematuria, proteinuria. Skin manifestations of vasculitis could include purpura, gangrene, ulcers. The GIT can also be affected in some of the vasculitic disorders, which can result in severe abdominal pain, bleeding, perforation, intussusception. And some of the vasculitis can even affect the eye, which can manifest as keratoconjunctivitis and uveitis. So if you look at the classical manifestations of vasculitis, they would depend on whether it's affecting the small vessel, medium-sized vessel, or a large vessel. And typically, the manifestations of a small vessel vasculitis would include skin in the form of ulcers, purpura, or a pulmonary renal syndrome. A medium vessel vasculitis may be characterized depending on the vessels affected in the form of abdominal pain, or like in polyarthritis nodosa, or hypertension. Some of the medium vessel vasculitis can result in stroke. Large vessel vasculitis typically is characterized by hypertension, congestive heart failure, absent pulses. So if one has to evaluate a patient of vasculitis, child with vasculitis, there are certain general tests that have to be sent, including CBC, activity markers like ESR, CRP, renal function, urine examination, protein creatinine ratio, because these are chiefly when the kidneys are commonly affected. If it's a large vessel, then generally an initial investigation could be an ultrasound Doppler, followed by angiography, which can clinch the diagnosis. For a medium vessel vasculitis, again, depending on the disease, whether it is Kawasaki, then you could do an echocardiography and you can look at and find aneurysms. Or for a polyarthritis nodosa, angiography is necessary because then it would show classical manifestations of aneurysms, dilatations, and stenosis. And occasionally, nerve or skin biopsy may be needed for medium vessel vasculitis. For the small vessel vasculitis, the histopathology has a key role, and it generally is diagnostic. When these small vessel vasculitis affect the kidney, or if they affect the lung, then even a lung biopsy. The ones that affect the skin predominantly, like the IgA vasculitis, one could find leukocytoclastic vasculitis evidence on the histopathology. CT sinuses in chest may be useful given the symptoms of the patient. And a very important serological marker is the ANCA. And I'll be discussing more in detail about the ANCA in my subsequent slides. So there have been multiple classifications which have been modified over the period of time. And the last classification of vasculitis has been the consensus Chapel Hill Conference of 2012, where the vasculitis has been classified into a large vessel, which includes Takayasu arthritis, giant cell arthritis, medium vessel, polyarthritis nodosa, and Kawasaki disease, and small vessel vasculitis. The small vessel vasculitis has been further classified, and this is based on pathological, based on the pathology, that if it is driven by the ANCA antibodies, then it is labeled as ANCA-associated vasculitis, which includes microscopic polyangiitis, granulomatosis with polyangiitis, previously referred to as Wegener's granulomatosis, and eosinophilic granulomatosis with polyangiitis, EGPA, or what was previously called as Children's disease. On the other hand, the small vessel vasculitis is because of the immune complex deposition, and these would include anti-GBM disease, cryoglobulonemic vasculitis, IgA vasculitis, which was previously called as Henoch-Schönlein, purpura and nephritis, and hypercomplementemic urticarial vasculitis, or NTC1Q vasculitis. In addition, there are certain other sections in the classification, such as variable vessel vasculitis, or a single organ vasculitis. And apart from these primary vasculitis, there could be secondary forms of vasculitis where the vasculitis is associated with a systemic disease like lupus or sarcoid, or sometimes when it is associated with the probable etiologies, infections such as HCV, hepatitis B, or drugs like levamisole, etc. In fact, at least two monogenic disorders have been described, which can result in vasculitic illness. One of them is the deficiency of the adenosine deaminase 2, which can mimic polyarthritis nodosa, and the other is the one that mimics Behçet's disease. So to demonstrate as to how one can approach a patient with of vasculitis, I would present a case where this 15-year-old boy presented to us with symptoms for last 20 days, fever, myalgia, polyarthritis, upper airway involvement in form of blood-tinged sputum, subconjunctival hemorrhage, and he was found to be hypertensive. He also had a skin rash, which was in the form of palpable lesions, which were chiefly on the lower limbs. So this patient has multiple various systems affected, including the musculoskeletal, systemic symptoms are also there. And so that this does point towards a condition which would be either a connective tissue disorder or a vasculitis. And the investigations revealed the child had renal dysfunction in the form of deranged creatinine and low serum albumin and a nephrotic range proteinuria of 2 grams per day with an active urine sediment of 30 to 50 RBCs per high power field. So based on this, when we had a strong suspicion of vasculitis, further serologies were sent. ANA was negative, C3 was normal. However, the PR3 ANCA was significantly or strongly positive. The chest X-ray showed multiple bilateral infiltrates, which on CT revealed bilateral consolidation of lung. There was maxillary sinusitis on this CT of the sinuses, and the kidney biopsy revealed necrotizing glomerulonephritis with crescent formation. So most of you would have guessed the diagnosis correctly, that this is granulomatosis with polyangiitis, or GPA, which was previously called as vaginous granulomatosis. So how are ANCA-associated vasculitis disorders classified? They're classified into either granulomatosis with polyangiitis or microscopic polyangiitis, and the third is the eosinophilic granulomatosis with polyangiitis. For GPA, there are at least 6 criteria, of which at least 3 should be present, which could be renal involvement, histopathology showing granulomatous inflammation, upper airway involvement, laryngotracheobronchial involvement in the form of either stenosis, lung involvement either on the X-ray chest or a CT chest, and even the ANCA positivity is also included as one of the classification criteria. For the macroscopic polyangiitis, there could be presence of necrotizing vasculitis on a histopathological specimen. Lungs can be involved, and there could be rapidly progressive glomerulonephritis. Occasionally, you can find that the disease is only limited to the kidneys, when it is called as renal limited polyangiitis. For eosinophilic granulomatosis, the symptoms, criteria would include asthma, like features, presence of eosinophilia, necrotizing vasculitis on histopathology, and eosinophil-rich granulomatosis in the respiratory tract. So what are these ANCA antibodies? These are the antibodies that are produced against the neutrophil antigen, the proteinase 3 or myeloperoxidase, and they have a classical staining on immunofluorescence, which is typically cytoplasmic in the form for the proteinase 3 with PR3, which is called C-ANCA, or perinuclear, which is the MPO against the MPO when it's called the P-ANCA. However, there are other ANCA antigens as well, which is LAMP2 and elastase. And ANCA is also seen in several other diseases like inflammatory bowel disease when the antigens are different. Natural ANCA is also present in some of the healthy individuals, but in low titers, and it has very less avidity and is not pathogenic in the absence of symptoms. So for the diagnosis of ANCA-associated vasculitis, the criteria are being developed, and particularly for the GPA, they've been defined. Biopsy is strongly supportive of the diagnosis of ANCA vasculitis, and ANCA antibody presence is highly specific, but it's not mandatory, because we know that about 7 to 10% of microscopic polyangiitis or GPA can be ANCA negative, and about 10 to 30% of post-immune presenting gene can be negative for the ANCA antibodies. The mechanism there could be that the neutrophil activation is either mediated by antibodies that have not been screened for, like ICA or LAMP2, or it could be a cell-mediated driven mechanism. Now, a word about how to test ANCA antibodies. And the EULAR recommendations in 1999 suggested that ANCA was best tested by both immunofluorescence as well as ELISA. That suggested that you screen first by immunofluorescence and later confirm it by ELISA. Significant innovations have happened in both ELISA testing and indirect immunofluorescence for ANCA. And there are new solid phase immunoassays that have become available. And in 2017, the UVA study revealed that in a large number of ANCA patients, they compared the indirect immunofluorescence as well as the ELISA methods. There was a large variability in the immunofluorescence methods. However, immunoassays performed much better with higher specificity than the ELISA, than the immunofluorescence method. And you could see that this receiver operator curve that is presented here, the green one shows the immunoassay that have much better diagnostic accuracy as compared to the indirect immunofluorescence methods. If it's the MPO for the first generation, or what is called as direct methods, are as good in terms of sensitivity. However, for protein S3, the third generation ANCA have much ELISAs have much better sensitivities. So the new approach is that if you suspect ANCA-associated vasculitis, then one should do the immunoassays for PR3 and MPO. And if you have the ANCA is negative, but you very strongly suspect ANCA positivity, then the second assay could be an indirect immunofluorescence. On the other hand, if you get a weakly positive ANCA, one could again subject the patient to immunofluorescence. One should also understand that about 9 to 17% of ANCA vasculitis will be negative. The antibodies will not be there by either the immunofluorescence or ELISA. And antibody missed by one test can be detected by the other. So one can use it vice versa. And the position paper clearly stated that screening by immunofluorescence adds little to the high quality immunoassays if the pretest probability is high. Here are some of the indications for testing ANCA, which includes RPGN, pulmonary hemorrhage, cutaneous vasculitis, lung nodules, long-standing sinusitis, otitis, etc. So how does one approach a child or patient with ANCA vasculitis who is suspected to have? So you would do standard tests like renal function, complete blood count, chest X-ray, CT chest or sinuses if there are suggestive symptoms. Urine protein creatinine ratio, urine examination is very important. And then, of course, the ANCA antibodies and renal histology or lung histology generally sometimes is actually conclusive for the diagnosis. So the new KDIGO guidelines of 21, they suggest that if you have a kidney vasculitis suspected and you find that the ANCA antibodies are positive and you have a very low suspicion for a secondary vasculitis, then one could initiate treatment for ANCA-associated vasculitis and biopsy may be done soon whenever feasible. However, if the ANCA is negative, then and there is a possibility of other forms of vasculitis, then the biopsy should be done first before the treatment is commenced. So how is ANCA vasculitis treated? And over the years, in the last 30 years, there have been several landmark trials in ANCA vasculitis in adults that have shaped the protocols for treatment of ANCA-associated vasculitis. And for children also, since there is dearth of studies in children, and therefore the management is chiefly adapted from the adult trials. Starting from the 1990 PEC study, then the MEPEX trial, which established the role of plasmapheresis in the treatment of ANCA vasculitis, and the Cyclops trial, which where in the IV cyclophosphamide became the standard of care. Then in 2010, there were the rituximab was added to the armamentarium of the induction therapies for ANCA vasculitis. Rituximab was a further extension of RAY where they used rituximab in patients who had severe nephritis and found it to be not inferior. And very recently, the Advocate study, which showed that avacopan, which is a C5a inhibitor, can be used if you want to avoid steroids, because avacopan versus the steroids and the standard treatment of the vasculitis resulted in similar results. And very recently, the PEXIVA study, which has actually created a stir, whether PEX is actually useful in the long run in terms of mortality as well as renal survival. And at the same time, there have been studies which have shown that even low-dose steroids are as effective as high-dose steroids in the induction treatment. And now, these are the lower down, you have the various studies over the last 20 years, which have shaped the management of maintenance therapy of ANCA vasculitis, including the Cyclophosphamide study where azathioprine replaced cyclophosphamide as maintenance treatment. The Improve study, which showed that azathioprine was superior to mycophenolate. And then even rituximab was being used as a maintenance agent. The Menlicent 1, 2, and more recently the RITA-RM study, which showed that rituximab was superior to azathioprine in maintaining remission, in relapse-free remission in children, in patients with vasculitis. And in addition, there have been 2 trials which actually looked at the length of the maintenance treatment from 2 years to 4 years. And the REMAIN study found that if there was a benefit, there were much less relapses if the treatment was continued for a longer period. So this is the KDIGO guideline in 2021, which on ANCA vasculitis, where, and this is a very robust guideline, it's a very trustworthy guideline because it's chiefly dependent on the evidence. And they have given recommendations only in those areas where there's sufficient amount of good quality studies, the randomized controlled trial or systematic review. And they've come up with only just 2 recommendations for the ANCA vasculitis treatment. So the first one is the steroids with cyclophosphamide or rituximab should be used as the initial treatment for new onset ANCA-associated vasculitis. And this is a strong recommendation. For the rest of the things, they are given as practice points because the evidence was not compelling. They suggest that there is limited data to support rituximab in the treatment of rapidly declining or rapidly progressive glomerulonephritis when the creatinine is more than 4. Cyclophosphamide and glucocorticoid should be preferred in that situation. And this is chiefly because there's only one study, the rituxivas, which did show that it can be used. So due to lack of enough studies, they suggest that one should still prefer cyclophosphamide and steroids. For the plasma exchanges, if the serum creatinine is very high, more than 5.7, or there is diffuse alveolar hemorrhage in patients who are also having a hypoxemia, PEX should be considered for at least 7 in the first 2 weeks. They also suggest IV cyclophosphamide and rituximab as a combination because one of the rituxivas trial actually used this as a combination, and so they suggest that it can be an option. Rituximab is also preferred. They suggest that it could be preferred for non-severe GN in children wherever you are looking at steroid sparing or for relapsing disease. As far as maintenance is concerned, they have one guideline recommendation that says one should use either rituximab or azathioprine and low-dose steroids after induction of remission as a maintenance treatment, and this is important. They say that you could prefer rituximab if there is relapsing disease or PR3 ANCA positivity, or when you're looking for steroid sparing, because after 6 months, after the induction, you don't need steroids along with rituximab if you're using rituximab. On the other hand, one would prefer using azathioprine if there is a low baseline IgG, less than 300 milligram per deciliter, because then there is higher risk of developing hypogammaglobulinemia following rituximab. If there is rituximab non-availability, hepatitis B positivity. They suggest that optimal duration of azathioprine plus low-dose steroid should be at least 14 months, between 14 months to 4 years after remission. For refractory disease, KDIGO suggests that one should increase steroids and use cyclophosphamide or rituximab if they have not been, whichever is not been used previously. So based on the KDIGO guidelines, and very recently the CARA guidelines have been published in 2021 March. The CARA guidelines are for children, and they are chiefly consensus-based guidelines, which have looked at the other adult guidelines for treatment of ANCA vasculitis. This is if we combine the two, then this could be one of the protocols for treatment of ANCA vasculitis. IV methylprednisolone dose between 15 to 30 milligram per kg, 1 to 3 doses. So again, the evidence for this is poor, and they say that even one has to look at whether IV methylprednisolone is needed. So this may be examined subsequently. In terms of, as far as oral prednisolone is concerned, there is an inclination towards reducing the dose of steroids, and most of the studies are now saying that we could even manage with low doses of corticosteroids in the induction period. Instead of using 2 milligram per kg, therefore 1 to 1.5 milligram per kg may be sufficient in the first week, and then decreasing the dose to 1 milligram per kg in the second, and to taper to up to 7.5 to 15 milligram per day by day month 3, and 5 to 10 milligram by 6 months. So most adult studies where steroids were reduced to 5 milligram by 6 months. And this is what KDIGO recommends. The CARA guidelines, however, recommend higher doses of corticosteroids. For IV cyclophosphamide, the dose is 15 milligram per kg every 2 weeks for 3 doses, followed by 3 weekly for next 3 doses. And this is because these most of these adult trials have used this kind of a regimen. So the CARA guidelines, on the other hand, suggest that as an alternative, one can use the NIH protocol of Lupus, which is 500 to 750 milligram per meter square for weekly for 6 doses. For rituximab, one can either use 375 milligram per meter square weekly into 4 doses, or alternatively, one can use 750 milligram per meter square 2 weeks apart. And plasma exchanges should be at least in the first 2 weeks. And they're also indicated if there is in addition, anti-GBM positivity. For maintenance, azathioprine and steroid combination is to be used 1.5 to 2 milligram per kg for 24 months, then 1 milligram per kg for the next 2 more years, and then tapered and stopped. Prednisolone at least for 24 months, and then tapered by 1 milligram every 2 months. So then you are perhaps stopping before the 3rd year, and then the 4th year you only give azathioprine. Alternatively, one can use rituximab as maintenance agent in the dose of 375 milligram per meter square 2 doses, or 750 milligram per meter square 1 dose at 6, 12, and 18. Ritazaram study, in fact, used every 4 monthly rituximab and found it to be better than azathioprine. So to summarize, we need multicentric studies for childhood vasculitis. There is, if you are doing ANCA testing with high quality immunoassay, then that should suffice, and immunofluorescence may not be needed. Pediatric specific therapy guidelines are required, and with the current evidence, one can say that corticosteroids and IV cyclophosphamide are the key treatment for induction therapy in ANCA-associated vasculitis. Rituximab can be used as an alternative. Plasma exchanges are recommended for severe nephritis. However, the long-term benefits are unclear. Prolonged maintenance with rituximab, it can also be used as a maintenance therapy. It prevents relapses. Thank you very much for your patient listening.
Thank you for the detailed introduction, sir. Very, very detailed and elucidated, and also very good overview of the treatment as well. So I request my co-chair, Dr. Sana, to introduce Dr. Raju Sinha. We have one question from the audience. Dr. Nivedita Pandey from Pune has raised a question on management of hydroarthritis. I think Dr. Suma Balan is having a talk on that, and I think she'll cover that point. We'll discuss that point later. So probably we can proceed with Raju Sinha's talk. I request my co-chair, Dr. Sana, to introduce Dr. Raju Sinha.
Good evening, everyone. It gives me immense pleasure to introduce Dr. Rajiv Sinha. Sir doesn't need any introduction. He is a pediatric nephrologist in Institute of Child Health Hospital, Kolkata, and he is head of the Department of Pediatric Nephrology. And he is also practicing as a consultant pediatric nephrology in Apollo Jingles Hospital, Kolkata. He has more than 15 years of experience in the field. He is a UK board-certified pediatric nephrologist and recipient of multiple travel grants from ISN, IPNA, BAPN, ESPN, and ASN. Sir has more than 80 publications in both national as well as international peer-reviewed journals, including 18 original articles. He has as well contributed in multiple book chapters and reviewer of multiple indexed journals. Over to you, sir.
Am I audible?
Yes, sir. Yes, sir. Please go ahead.
Yes, sir.
Okay. Let me see how I share. So what do I do? Yeah. Okay. Is it visible now?
Yes, yes.
Okay. So first of all, thank you very much. And what I liked was that in my introductory slide, it was mentioned pediatric rheumatologist. I'm not sure whether Satish is around. I'm sure he will love it, that I'm now also a pediatric rheumatologist. And I'd like to thank Dr. Subal and Dr. Himes for organizing this. And I'd like to thank all the pediatric rheumatology community for doing this jointly. And a special thank to our foreign faculty, particularly Dr. Tulas, who will be around the whole session for answering difficult questions. So what am I supposed to be doing is give a quick update of lupus nephritis. And we start with a standard case scenario of an 11-year-old girl, febrile, myalgia, malaise, oral ulcer, and investigation showing a slightly low hemoglobin, neutropenia, platelet on the lower side, urine showing some amount of protein. 24 hours protein is 984. Creatinine is slightly raised at 0.8, and the C3 is low, C4 is low, ANA, dsDNA is positive. So I'm sure we all know that this is a child who has a most probably lupus nephritis, and we have got set criteria like when I was in our MD period, we used to mug up those 7 criteria from the American, and subsequently we had this SLIC criteria, and as you can see that our child is fulfilling the SLIC criteria. And very recently there has been a slight modification wherein they have said that ANA positivity is important for us to diagnose SLE. So we used to have those argument, and I'm sure that we still have that argument that whether there is anything called ANA negative lupus. But as per this recent criteria, there is nothing called ANA negative lupus. If you are having a lupus nephritis, if you want to stamp as a lupus nephritis, you must have a ANA positivity, and then there are various scoring systems in the clinical domains and the immunological domains which you add up, and if it is more than 10, then your child is having a lupus diagnosis. And I'd like subsequently in our discussion for Dr. Tulas and the rest of our rheumatology community to comment on this presumption that there is nothing called a ANA negative lupus. So going back to this child, now we know we have a child with lupus. Next thing is to look at the kidney. Why? Because as this study showed from Toronto, that kidney is among the most common important organ that is involved in lupus. And this is a very important take-home slide, which shows that not only kidney is the most common important organ, but it also has a huge impact on morbidity and mortality, particularly long term, because CNS usually is influence is short term. So kidney has both short term as well as long term, and that's why it is very important. And I hope our rheumatology colleagues remember, as well as the pediatricians, that you do need your friendly neighborhood pediatric nephrologist, which nowadays is quite freely available across India. And usually what we do is go for a kidney biopsy. What are the indications for doing a kidney biopsy in lupus? This is a ACR criteria. Say sepsis, hypovolemia, or some medication, nephrotoxic medications. No, you have excluded that, but the creatinine is high, then you go for a biopsy. Proteinuria more than 1 gram, or even less proteinuria around above 500 milligram, provided you are having active urine, like having RBCs or cellular casts. But this criteria is not set in stone, and there has been studies showing that even with low proteinuria, as low as say below 250, you can end up having significant renal lesions. Significant renal lesions, which I mean is class 3, class 4, and 5. I'm sure most of us are aware of these classes, and we'll discuss it subsequently. So keeping this in mind, what the recent SEER initiative has highlighted is that you have got all those criteria for the significant proteinuria, but even in low proteinuria, if the proteinuria is persisting, and if you have a child with lupus or suspected lupus, then that child merits biopsy. After biopsy, what we do is we go look at the pathology and then classify, which can range from class 1, which is practically a normal light microscopy or the minimal change in the light microscopy with only immunofluorescence positive, to class 2, where it is a mesangial proliferation, class 3 and 4, where you have got the endocapillary plus minus extracapillary proliferation. If this proliferation of the is limited to just focuses, then it is focal, and if it is diffuse, then it is called diffuse lupus nephritis. And we have got the membranous lupus nephritis, and class 6 is the everything is dead. So it is the sclerosed. More than 90% of the globe is sclerosed. 2018 subsequently has further introduced this activity index and chronicity score. And before also we were saying active chronic, but here we now have a specific scores there. And what is hoped is that using this routinely will help us in not only prognostication, as well will also help us in future in identifying medications which are better. Despite all this modification, the current classification has got some fallacy, of which the most important is that still does not cover some of the lesions that can rarely be found if you are doing a biopsy for lupus. For example, it does not cover lupus podocytopathy, collapsing lupus myelopathy, or certain important vascular lesions like thrombotic microangiopathy. So that is not present in the classification per se, but it's important for us to note because it can have a different management plan. We all know about the full house of poker for the immunofluorescence. These children with lupus usually have IgG, IgM, C3, C1q, IgA, and which is quite classical with lupus nephritis. But again, remember that in medicine, there is usually nothing called always. So there are differential diagnoses for this, and certain other diseases can also present with full house immunofluorescence. Once we have done the biopsy and once we know what sort of classification we have, basically we have to see whether it is a proliferative lupus nephritis or a non-proliferative. For the non-proliferative lupus nephritis, which includes class 5 lupus nephritis, usually we don't go for any immunosuppression unless and until we are having nephrotic range proteinuria. For proliferative lupus nephritis, we go for the immunosuppression, and proliferative are usually class 3, class 4, and a mixture of class 3, class 4 with class 5. Along with the immunosuppression, we also use the kidney protective measures, and we'll discuss this subsequently in more details. Important thing, we have already highlighted that please, when you are reading the biopsy, look out whether they have identified certain other things which are not classified in the which are not included in the standard classifications. So what is the standard of care immunosuppression for childhood SLE nephritis? We have already said that immunosuppression is important for the proliferative lupus nephritis. So what is the standard immunosuppression for the childhood SLE nephritis? Sorry, I missed the nephritis part. So it all started in the 1960s when it was identified that the use of steroid definitely improves the survival for patient with lupus nephritis. But steroid, as we know, has got a lot of side effects. And subsequently, there has been certain landmark trial, starting with the NIH trial in 1986, which compared a steroid plus immunosuppressant and only steroid, and showed that yes, cytotoxic drug is useful. Subsequently, they compared just a IV methylpred versus a cyclophosphamide and found that yes, cytotoxic drug is useful. And in 1996, they compared IV methylpred or IV cyclophosphamide versus combination therapy, and again, and this time said that yes, steroid is useful, cyclophosphamide is useful, and if you combine the two, then it is more useful. And for a long time, this cyclophosphamide became a standard of care, because the studies also showed that long-term cyclophosphamide is better than short-term cyclophosphamide. But we all are aware of the various side effects of steroids. We are all aware of the various side effects of cyclophosphamide. So Chan et al. Came up with this one of the real landmark paper of recent time in 2000, where they showed that MMF is as effective as cyclophosphamide, and that sort of resulted in a reduction in the use of cyclophosphamide if required. In 2002, we had the Lupus trial, which showed that if you are worried with high-dose cyclophosphamide, why not use a low-dose cyclophosphamide? And they said it is of equal efficacy. So now we have got two options. Either we can use MMF or we can use IV cyclophosphamide low dose. And there were a number of studies which showed that they are of equal importance, equal efficacy, and few studies even showed that maybe MMF is superior to cyclophosphamide in Hispanics and Blacks. And in 2011, there was this arms maintenance study which showed that for maintenance, we were using MMF or azathioprine. Cyclophosphamide was already out, but this showed that MMF is superior to cyclophosphamide. So by 2011, what was happening is for induction, steroid plus minus either cyclophosphamide or MMF, and for maintenance it is MMF. Whether adding rituximab is beneficial or not, well, there were many anecdotal reports with rituximab being benefit, but this lunar RCT did not show any benefit. In 2015, we had one of the first definitive proof that triple therapy, that is TAC, MMF, prednisolone, is as useful as cyclophosphamide and PRED, and maybe we can get away with lower dose steroid. And just very recently, and we will discuss this subsequently in a slightly more details, we had the Aurora trial and the Bliss trial, proving that yes, addition of belimumab and addition of valcosporin might be useful. And this Aura just recently, this was what is shown here is 2018, but it had a full and final report in 2021. So based on this, a number of guidelines has come up, starting from the 2012 guidelines, and we now have got the 2021 guideline, and I will be quickly going through the 2021 guideline in the next few minutes. Non-immunosuppressant hydroxychloroquine is a must, and it is a sort of mandatory for every child with lupus nephritis, because it helps in lupus, it helps in reducing flare, it helps in cardiovascular. Speaking of cardiovascular, these children and the adolescents are at higher risk of cardiovascular risk, so a lifestyle modification, dyslipidemia control is important. Controlling proteinuria with ACE blocker is important, and avoiding high salt diet. Be on the lookout for infection, because they are going to have a steroid for a long time, so calcium supplement is often given. Ultraviolet sunlight exposure is important, and all children with lupus should use this broad spectrum sunscreen. A premature ovarian failure has been identified, and although I don't think it has been used commonly, but there are some advocacies of gonadotropin releasing hormone agonist use. And teenagers, which many of these lupus are, girls, teenagers should be advised about contraception because many of the drugs that we are using for lupus have teratogenic, particularly MMF, and they have been shown to have a long-term cancer risk, so they should be under surveillance. Immunosuppressant, we have already said for class 1 and class 2, usually it is not required unless or until it is they are having a proteinuria. And usually for lupus photocytopathy, treatment is more or less like a minimal change. For class 3, class 4, that is the proliferative lupus nephritis. If it is if the chronicity index is high, then again supportive treatment. Otherwise, it is a steroid, as I said, plus MMF or cyclophosphamide. Now, what this, very important, what this a new guideline has is a bit different is that they have stressed on a low dose steroid when compared to the previous guidelines. And in addition to that, they have also introduced the use of CNI or B lymphocyte targeting biologics, either rituximab or belimumab, as an add-on therapy. As I said, that they have compared to the previous one, they are emphasizing on low dose steroids. And for the cyclophosphamide, if you are using it, then it is better to use the Eurolupus protocol of a low dose cyclophosphamide rather than the high dose cyclophosphamide. So our particular child came up with a SLE nephritis type 4 and was treated with the pulse methylprednisolone prednisolone MMF along with what we just discussed, and at 6 months seemed to have responded quite well, afebrile with normal activity. Urine RE was protein was 1+, and RBC 10 to 15. And if we look as per the response criteria from KDIGO, seems to have gone into a complete response. Now, this is very important that you do get a good remission. Why? Because studies have shown that a good remission means a good outcome. This study showed that a low creatinine at 6 months, a controlled protein, urinary protein at 6 months means a good outcome. Again, study showing that those who are having a complete remission complete remission is best, but even partial remission is better than no remission. Something akin to what we believe in steroid-resistant nephrotic syndrome. And the bottom panel showing the importance of having a 24-hour urinary protein under control. But lupus is a long road. And we do have ups and downs in lupus. Anyone looking after lupus knows about this quite frequently. And this was a study from AIMS showing that average they can have a 0.16 episodes per person per year of flares. And there are studies, and these are the types of flares you can have: proteinuric, nephritic, or AKI. And there are studies which have shown that more flare means worse outcome. And there are studies which have shown a value of repeat biopsies in lupus nephritis flares, which can change management. And because of this tendency to flare, we need a maintenance immunosuppressant. And what can be used? As per the guideline, the first choice is the MMF, and but we can use azathioprine tacrolimus also. Class 5 lupus nephritis, we already said low level proteinuria. Usually you often don't go for immunosuppressant, and you depend more on the RAS and on the RAS blocker along with SCQ. High level you can go for immunosuppressant, and there are studies which shows that CNI might be useful in this. Now, with all this, what is the outcome? Outcome is not really that good. You see this very shows that a complete remission happens in about 50 to 60%. Same thing here, complete remission around 50 to 60%. And this was a study where they did a biopsy at 1 year and showed that many of them continue to have a good activity in index. And what was very disheartening, that the chronicity index had further increased. studies showing that the high incidence of CKD in lupus nephritis, and they do have lot of disease associated morbidity, including this study we showed a disease associated morbidity along with lot of steroid induced morbidity. So definitely there is room for better. And what is happening with lupus is that lupus is a very complex disorder. I don't understand it at all. A number of molecules are involved. I had attended a couple of dedicated conferences on lupus, and it was so much of immunology, and that is where the fault is, that we are not targeting all the molecules. A number of studies are going with the various molecular target, and recently we had this study from the belimumab, and then the voclosporin, and then the obinutuzumab, and all of these three are compared here. And what you see is that adding on this really does make some difference, and this resulted into this very recent publication in KI that maybe we are having a management renaissance in lupus nephritis. All these three studies are good. The Aurora, that is the voclosporin, the Blaze, that is the belimumab, and the Nobility, that is the obinutuzumab, that they looked at diverse population, and in all these three, efficacy was seen and it was sustained. And but they did not have much comment on the class 5 lupus nephritis, and so further studies definitely are needed. But then this particular publication has come out with some suggestion where to use these new drugs in the flow chart, and I'm sure you can access it later on. What is new? What is new? Yeah, another 2-3 minutes I will go for. What is new is that can we combine rituximab with belimumab? We know that RCT showed that rituximab doesn't work, but there are studies which have shown that prospective studies which have shown that it can be quite useful. And I think we should look out for this calibrate study which is combining rituximab with belimumab, and this is supposed to be, to me, a more of a low-lying fruit which might be useful in reducing flare as well as reducing the steroid dose, but cost will be a important factor. Refractive lupus nephritis, I'll just run through it. We don't exactly know what is refractive lupus nephritis, and adherence is very important, and if the adherence is ruled out, make sure that it is not other causes of other kidney causes like a thrombotic macroangiopathy, etc. If that is ruled out, then you can switch therapy. That if you're on cyclophosphamide, then try MMF, and then you can go on adding rituximab, plasmapheresis, etc. When to stop treatment? Most of us are afraid of stopping treatment even after 2 to 3 years, but maybe a guidance through a biopsy might be useful. Last, I always end up with this 10 common mistakes which was brought up by the Silverman-Bauman group, which I find very important. So assuming that cyclophosphamide is the gold standard induction agent, one mistake: improper dosing of steroid. Either we go for very high dose or low dose, maybe high dose initially, but rapidly tapering down. Not using XCQ, not using sediment for response criteria, not scaling intensity of immunosuppression to the different classes of nephritis, missing non-adherence, not reducing or minimizing immunosuppressive exposures in patients with advanced kidney disease. Like if the kidney is gone, why are you going on giving immunosuppression? Forgetting to monitor the side effects and the prophylaxis use, performing a biopsy on the kidney when it will not affect therapy. So if you have a very sick child with lupus, you can wait for the child to get stabilized and then perform the biopsy. I'd like to invite all of you to contact the ICH Nephrology for at this email because we are running a childhood SLE nephritis registry, and please do contribute. And lastly, when life gives you lemon, make lemonade. All of these celebrities with lupus must have made the lemonade. Thank you very much.
Thank you, Dr. Sinha, for the inclusive talk. There's one question from my colleague, nephrologist, pediatric rheumatologist from Kolkata, Dr. Suparna Guha. Her question is, does every child with lupus need biopsy according to the recent SHARE guidelines?
Yeah, that's what I was saying, and we did share that evidence that even low grade proteinuria can have significant lupus nephritis. We have got with us various experts also from abroad. We have got Dr. Chel with us, as well as Dr. Eve Smith, and so any of them, and Louis, any of them can share their. I think this is an important question, and with your permission of the chair, if sure. Dr. Chel, Louis, or if any of you want to comment.
Could you please rephrase the question for us? Exactly how it's.
So, does every lupus kid needs a biopsy, kidney biopsy, and even with the low proteinuria, and how low proteinuria you'd biopsy?
Well, I'm sure we could debate that. I think it's important to know if a child has a lupus nephritis, because as you very much pointed out, the kidney disease is one of the long-term important parts of the lupus for every child who's got it. I don't specifically have a limit to the protein. If you have proteinuria in a child, it's most of the time really pathological. Most children don't have that. And if you have a confirmed proteinuria and the child has significant lupus, then I personally would like to have a kidney biopsy.
So I think that's a clear-cut message which we have been trying to give to our rheumatology colleague, and that's how it is changing, that persistent proteinuria, even if it is on the lower grade, the child merits a biopsy. And biopsy now with percutaneous biopsy, ultrasound guided, finger crossed, is becoming quite safe. So we should go ahead.
Thank you. And in fact, you highlighted that pitfalls that we should not rely on the urine proteins for the severity of the lupus nephritis in the last slide. That was quite interesting. Thank you, Dr. Sinha and Dr. Hari, for this very interesting first session. With this, I think I will hand over on behalf of my co-chairs, Dr. Sushmita and as well as Dr. Afsana, and go to the next session. And I thank Dr. Subal Pradhan, who was the kind of key organizing person for this meeting. And as promised, after October 2021, we had the second meeting on the second renal rheumatology update. Thank you. Over to moderators.
I think it's up to me then, if I understand it correctly. Please interrupt me if I'm wrong. And I've been given the honor to introduce the next three chairmen. Well, some of you here will know me, of course. I work at Great Ormond Street, and I love to come to India. Mainly because also my daughter, as many of you know, lived in India for a number of years. She's now moved away, so I'm not coming as often. But it's nice to come in this way at least. So let's go to the chairman. Firstly, I'm going to introduce Dr. Subal Pradhan. He is an associate professor in Odisha, which I'm sure all of you know much where it's located, but I've looked it up on the map, so I do know, not too far from Calcutta. Dr. Pradhan was trained in Bangalore. He's part of the Indian Society for Pediatric Nephrology. He's also been trained in Canada and in Birmingham. And he's written a good number of papers and been part of editing a very important book, Practical Procedures in Pediatric Nephrology. And one of his main interests are glomerular diseases, which is, of course, what we are talking about today. Second chairperson that I've asked to introduce is Dr. Satish. He's a professor in pediatric rheumatology in Vellore. He has also, after being trained in India, been trained abroad and spent 3 years in a hospital of sick children in Toronto. And he was the one who established and started the important rheumatology service in Vellore together with a colleague. And he's also been very prolific and written a number of national and international publications. And the third chairperson that I'm introducing is Dr. Pal, who is also a pediatric nephrologist, at this time from Kolkata. He's a professor in pediatrics and head of the Pediatric Rheumatology Service at the Institute of Child Health in Kolkata. He's worked intensively with the Pediatric Rheumatology Society of India, and he's now president-elect for the Indian Society for one of the other important vasculitic conditions, namely Kawasaki disease. Thank you all. I don't know exact, but I think I'm supposed to hand over the word to one of the 3 chairpersons now.
Thank you, Dr. Tulas, for your kind introductions. For the next sessions, I would like to invite Dr. Balan. So she doesn't require any introductions, though she is a pediatric rheumatologist. She is well known in pediatric nephrologist community, and her Erythematosus, juvenile idiopathic arthritis, SLE, and usual hand syndromes. She is well trained in India and abroad from Canada. And she has granted many international and national publications, and active member of pediatric rheumatology faculty in India. Over to you, Dr. Balan.
Thank you so much. I'm not able to. Yes, I'll show myself. Yeah.
Recording stopped.
Okay, so is my screen visible?
Recording in progress.
Yes,
Recording
yes.
stopped. Recording in progress.
So my remit today is to talk about the challenges in large vessel vasculitis management in children. I think Pankaj has already done a fantastic overview of vasculitis in children. So just to remind you that when we are talking large vessel vasculitis, we are predominantly talking about Takayasu arthritis. Sometimes there can be a bit of an overlap between the medium vessel vasculitic disorders like polyarthritis nodosa. And then sometimes you can have the variable vasculitis disease like Behçet's and Cogan syndrome, who can also present with large vessel involvement. So he's already been through most of the symptoms that should make you think about the different types of vasculitis. So the question comes, when would you start considering vasculitis in a child? This is not about when would you start considering large vessel vasculitis, but in general, when would you start considering vasculitis? So in any child with a pyrexia of unknown origin, one of the differential diagnoses in mind should be a vasculitic disorder, especially if there are multisystem manifestations. In any child who presents with a hypertensive emergency in childhood, especially if there is evidence of inflammation, then you need to be thinking about vasculitis being involved here. Then any child who presents with persistently raised inflammatory markers and even non-specific symptoms of unwellness is an indication to think about large vessel vasculitis particularly. And then children with recurrent strokes and multisystem manifestations with persistent inflammation are also a form of vasculitic presentations, particularly the monogenic vasculitis that Pankaj has already introduced us to, the DADA2. And the important thing is, most of the time in all these scenarios, we think about TB. We do need to start thinking beyond TB. So here is a 9-year-old girl who presented initially with a unilateral scleritis and anterior uveitis. She had raised inflammatory markers. I mean, the she was being treated by an ophthalmologist, and he gave her topical and systemic steroids, and he did ask her to meet a rheumatologist who did the inflammatory markers and advised further evaluation. But as she improved with the topical and systemic steroids, the family did not do that. And then 4 months later, she presented in our emergency department with seizures in a hypertensive emergency requiring intubation and ventilation. And what was salient was that there was a history of intermittent low-grade fever. She had very high inflammatory markers with inflammatory kind of counts, that is neutrophilic leukocytosis, anemia, and thrombocytosis. Her ultrasound abdomen was querying the possibility of renal artery stenosis and bringing up different, different sizes of the kidneys. So then the next thing we went ahead, we did a CT angiogram, and that showed multiple pseudoaneurysms in the descending thoracic aorta, quite a large one actually, and bilateral renal artery stenosis with SMA stenosis as well. She by now required 4 antihypertensives. The diagnosis was pretty clear. She fitted a diagnosis of Takayasu's arthritis. Actually, she was started on because of the appearance of the very, very active pseudoaneurysm in the descending thoracic aorta. She was started on cyclophosphamide along with steroids. An alternative here would have been to use an anti-TNF, but the family couldn't afford it. And she had a label of Takayasu's arthritis. After she was started on the steroids, had the first dose of cyclophosphamide, she came on follow-up of 3 weeks after she was discharged home. And then she was still found, though her inflammatory markers had settled, there was ongoing hypertension. It was not improving at all. Captable renograms showed a serial reduction in the right kidney size and function. So at this point, an endovascular intervention, right renal artery balloon dilatation was done, which actually significantly improved her hypertension, and she is currently stable on her treatment. She will go on the induction cyclophosphamide and soon change over her immunosuppression to maintenance mycophenolate or methotrexate. And she will be in steroids, and she will be followed up very closely for other aspects of her Takayasu's disease. And I think there were a lot of take-home messages here actually, that uveitis in children can often be an indicator to an underlying rheumatological disorder. And it is important that these children do have a proper evaluation at that point in time. And they need to have a very detailed examination, appropriate workup. In this particular child, there were no missing pulses. And that should not actually take us away from the diagnosis of a Takayasu disease. In her case, she had a hypertensive emergency, which is the other common scenario in which we diagnose this condition. And of course, like Rajiv was saying before, these patients need multidisciplinary care. There were 5 specialists who were looking after this child. And the other important thing is that intervention should be performed after the control of inflammation for the best long-term result. And we will talk about the other problems soon. So this is the kind of CT angiogram that she had, and you can see the kind, what I was talking about, the descending thoracic aorta and the typical renal ostial narrowing of the renal arteries on both sides, etc. So another child we will see quickly is a 5-month-old baby with high-grade fever, very irritable. She had some kind of intermittent rash over her body that was very non-specific. She again had features of inflammation. In the first hospital, she was treated as a UTI. Then she was treated as a lower respiratory tract infection. She was still not getting better. And 6 weeks down the line, she was in a 3rd hospital. And here an echo was done. She had dilated coronaries. So it was presumed that she had an MISC, though actually speaking, it doesn't really fit into the temporal profile that we can see here with an ongoing illness of 6 weeks. And she was initially given 2 grams per kilo of IVIG. She had, but that her coronaries did not change at all. So at this point, she was given steroids, first pulse with methylprednisolone and then oral steroids. And a good response was seen at this point. The echo, actually, it's not clear really whether the echo showed any improvement. That particular fact was not mentioned in the notes. And then she was weaned and stopped steroids, which we do for an MISC within a couple of weeks, 2 to 3 weeks. However, she developed fever and irritability again, and this time she was admitted in a 4th hospital. She was very anemic with very, very high inflammatory markers, and a bone marrow was offered, but the family refused it because they couldn't understand why it was required. And then she was started on methylprednisolone because of the persistent fever, irritability, and to their surprise, they found that the echo still showed a triple vessel dilatation with Z scores between 3.5 and 4.5, which is very significant dilatation, as we know. Again, she settled on steroids, but when she was weaning steroids, she started becoming symptomatic with a rising CRP again. And at this point, she was referred to our care. And this is a child I literally saw in about a week ago. And she was a very irritable child. She was afebrile at this point when we saw her. There was no hepatosplenomegaly. There was no rash. She was not growing very well. And the mother did report a poor appetite as the steroids were tapered. She continued to have very high inflammatory markers. So this, to me, it was quite clear looking at the entire picture, especially with the persistence of the coronary artery dilatation, that we are dealing with a primary vasculitis here. I presume that this could be infantile polyarthritis nodosa or a DADA2. And I wanted to do a bone marrow because some of these monogenic vasculitis like DADA2 can be associated with hematological abnormalities like red cell aplasias and immunodeficiencies, etc. And we did a CT angiogram as well. We've done the whole workup, ADA2 levels, and a whole exome was sent. And then this is what we saw when we did the CT angiogram. So she has an acute aortoarthritis with a complete occlusion of the second part of the right subclavian and near complete occlusion of the second part of the left subclavian. I went back after this and re-examined, and I could not get her pulses. Now, the important fact is that we had looked for the pulses earlier, but because she was so irritable and so small, she was actually very difficult to examine. And we didn't really know what we were feeling at that point in time, but now it was quite clear. And she also has diffuse mural thickening of the thoracic and abdominal aorta with some luminal narrowing, which suggests very active disease. So here we are dealing with an infantile aortoarthritis, which is a very unusual presentation for a, if at all it is supposed to be a DADA2 syndrome. This is more likely to be an infantile Takayasu disease, of which there are very, very few patients reported in literature. The other workup is still yet to come. And she's been started on treatment with steroids and immunosuppression. And now, this is a third baby whom we saw a couple of years ago. Again, this is a Maldivian child. So she has only come once to our hospital. Since 5 months of age, she came to us at 8 months. Since 5 months of age, she was having fever on and off, again, irritability, poor feeding, and weight loss. And when we examined her, she had hypertension, significant hypertension. She had had a number of transfusions because she was noted to have severe anemia. And again, she had significant inflammation to boot. She had a bone marrow done, which showed a red cell aplasia. She had multiple vascular aneurysms on her CT angiography involving the brachiocephalic, the right common carotid, bilateral internal mammary arteries, the bilateral renal arteries, pulmonary and left branch pulmonary stenosis, as well as a focal outpouching in the anterior wall of the arch of the aorta. We'll see the picture soon. And I really thought this baby was going to be a DADA2. And however, she did not. But DADA2 is a multi-system disease. Her ADA2 levels, which we sent off, were normal. Her immunoglobulin levels are elevated. They're usually on the lower side or normal in DADA2 patients, elevated as suggestive of an inflammatory disorder. And her whole exome sequencing, which we specifically sent looking for this, was negative. So there is no way we can actually make a diagnosis of DADA2 in this scenario. She's more like an infantile pan. However, in the time she stayed with us, we started treating her like a DADA2 with steroids and anti-TNF. She improved extremely well. She was playful, she was growing, her hypertension was improving, everything was better. And she went back to the Maldives when we got the whole exome and everything else back, which, actually, in retrospect, for an infantile pan, it would probably be better to give her cyclophosphamide instead of the anti-TNF, but we have not had any follow-up since then. So I do not know how she's doing. The last follow-up we had was about 8 months ago when the father reported that she was completely well. And this is the kind of CT angiogram picture that she had. You can see all the classic beading, the features of that you would see in a polyarthritis nodosa kind of patient, and the number of vessels that are involved. Now, the important thing about all these patients is that, it's about thinking about the diagnosis that will make you do the necessary tests to prove the diagnosis. So a childhood PAN compared to adults is a rare disease. And for the diagnostic criteria, it's mandatory to have either angiographic or histopathological changes. This child that I just showed you had angiographic abnormalities, and one of the following. So skin involvement, which we didn't have, myalgia, muscle tenderness, which she may have had because she was so irritable. It is difficult to definitively elicit that in such a young child. Hypertension, which was definitely there. Peripheral neuropathy or renal involvement is not present in this particular case. Here is another case of large vessel vasculitis. Now, this is not a child whom I have been personally treating, but I have been involved with diagnosing and also recommending the immunosuppression from distance. So this is a rare condition and not something that all of us will see. So this is a 9-year-old girl who had a long-standing history of frequent oral ulcers, skin lesions, eye changes, and she was just treated very randomly for each of these complaints. And then she presented to this medical college with severe hemoptysis and work of breathing and required ventilation, at which time the initial chest X-ray itself stood out and showed such significant abnormalities that CT angiogram was done subsequently, and this child was found to have a large vessel vasculitis, particularly involving both pulmonary arteries. The right pulmonary artery was stenosed and virtually obliterated, and the right lung was being supplied by collaterals which were coming from the bronchial arteries and from the descending thoracic aorta. The left pulmonary artery showed this massive aneurysm that you can see with an intramural thrombus, and there was also right subclavian stenosis and an infrarenal aneurysm present. And with the background that this child had, with the skin biopsy that she had, and with all the rest of the features, this is a Behçet's disease with a large vessel vasculitis. It's a very, very rare condition in children. It's usually found in young males, not in females. And the presence of predominant pulmonary artery involvement is what should alert you to the possibility of Behçet being involved in this case. Additionally, many of these patients will have early venous thrombosis, which can also be a pointer to the presence of pulmonary aneurysms. The prognosis is not very good. These are various other skin changes, retricularis, paniculitic lesions that can be seen as part of medium to large vessel vasculitis. And these conditions can also present with gangrene, which can be very destructive. And this may not be systemic pan, it can be cutaneous pan that presents in such a drastic fashion. It is much more common in children compared to adults, much more common in children compared to childhood systemic pan. And though the word cutaneous pan makes you think it's less severe, it can actually have quite significant complications. So it's a condition that needs to be treated quite significantly. And these are other findings I want to show you. This pyoderma gangrenosum. And this is also a boy with cutaneous pan who had this kind of vasculitic edema and pre-ulcerous lesions, paniculitic lesions, etc. So looking at Takayasu alone, it's an idiopathic large vessel vasculitis affecting the aorta and its major branches. It's quite a rare disease. It's 1.2 to 2.6 per million per year. About 30% of the cases apparently start in childhood. Usually they are children around a median age of 12 years. And it only comprises 1.5% of childhood vasculitis. So it's a disease that most of the time nobody thinks about. And that is one of the biggest challenges in diagnosing this condition. There are different types according to the kind of vascular involvement of the vascular tree. So you have, it's virtually self-descriptive. And in children, in all the series that have been reported, particularly from Asian countries, it is type 5 that is the commonest presentation that we see. So it's quite a significant form of Takayasu that presents in children. And in a nutshell, these are the problems. A lot of the clinical presentation of Takayasu in the early phases can be very, very non-specific. So people don't think about this diagnosis. And that is one of the biggest challenges that we undertake. And if the best prognosis of Takayasu disease is if we can diagnose it in the pre-pulseless stage, and when the findings can be quite broad, quite non-specific, it really requires that people think about this, are aware about this in a child who presents with a general unwellness, but persistent inflammatory state. And that's the only way we can improve our pickup of this condition before other complications set in. The second big challenge is recognizing disease activity. We can't rely only on CRP and ESR. If they're elevated, it's useful. The problem happens that if they are not elevated, it doesn't mean that there is no disease activity. Towards this, there are various disease activity indices that have been created. The PVAS is the Pediatric Vasculitis Activity Score from Birmingham. This is one that has actually been validated in children, but in the populations it has been validated in, the incidence of Takayasu is not very high. So, it's still, we need to see whether it will suit our children just as well. The ITAS, Indian Takayasu Activity Score, is a well-validated tool in adults. It's not that well-validated in childhood, but it is being increasingly used in childhood patients as well. ITAS-A is a combination of ITAS with inflammatory markers, which makes it even more sensitive to the diagnosis of Takayasu. The disease activity index estimation of Takayasu is the DATAC. That is also a very useful activity index that we have to find out what is the extent of activity of disease in the patient who presents to you. Angiographic changes are often used not only to make the diagnosis or to see the extent of disease, also to look at the activity of disease. The MRA or the magnetic resonance angiogram is the most useful if it comes for coming towards activity assessment, because it really visualizes the wall of the vessel extremely well. And that's where all the inflammation is happening in these patients. CT angiography also can, in skilled personnel, they can actually interpret disease activity looking at the thickness of the wall. However, in following subsequent assessments, doing repeat CTs can be very, very counterproductive, and it's often not recommended as a continuous disease, follow-up imaging for these patients. The magnetic resonance imaging makes the ideal follow-up imaging for these patients. However, it can sometimes tend to overestimate the extent of stenotic lesions, so we've got to be watchful on that. It's a very good follow-up tool. FDG PET is very well documented in adults in large vessel vasculitis. It does not have the same kind of, repertoire in pediatric vasculitis assessment. Biomarkers are very, very important because CRP and ESR are really not enough in this condition. There are a variety of biomarkers that are being studied. Nothing is consistently shown so far to be useful to use. The other very, very big challenge is balancing the medical treatment versus the intervention. And there are, like you saw the first case, she came with a hypertensive emergency. We know that the hypertension is mainly due to the renal artery stenosis. So why not just go ahead and dilate that renal artery? The thing is, there is enough and more evidence now, which tells you that at the point of intervention, if disease activity, if inflammation is controlled, the likelihood of this intervention being successful in the long term and the risk of restenosis is significantly lesser. So it is always important to see if you can have the time period to control the inflammation with immunosuppression and then do it when the right time comes. Sometimes patients present with very, very severe complications like a myocardial infarction or with aortic dissection, where you need to actually do a very, very quick and urgent intervention to save life. And this can be done, though these days we advocate using biologicals at this time to significantly bring down the inflammation and then go ahead with the surgery. How long will you treat a Takayasu? There is actually no definitive time yet because this is a very long-standing illness. We will come to that in a minute. And so diagnostic criteria, you have angiographic abnormalities of the aorta and branches is a must, along with other clinical features like decreased peripheral artery pulses, plus or minus claudication, hypertension, BP difference of more than 10 millimeter, upper limb and lower limb, and bruise over the aorta, major high inflammatory markers. So how do we treat these patients? The first thing is when you make the diagnosis, you try to assess the disease extent and activity. The initial treatment is use of corticosteroids with immunosuppressants. The choice of immunosuppressants is usually methotrexate, subcutaneous, or mycophenolate. And however, if you have very severe manifestations, you can consider in the kind of things that I have, situations I have shown you, you can consider biologics upfront or cyclophosphamide as the initial immunosuppressant agent. And one would tend, these days we use cyclophosphamide significantly lesser and lesser. In the patient I used it in, it's because the family really could not afford biologics and there was significant concern about the appearance of the aortic wall. But usually our regimen is corticosteroids along with either subcutaneous methotrexate weekly or daily mycophenolate. And then once you start weaning down your steroids to the lowest acceptable dose, we want to try and get down to really low doses in children. And if your disease activity is staying down, if your patient is staying well, there is no new kind of, no new vascular involvement and no new complications, then you can actually continue maintenance treatment and bring down the corticosteroid level to the absolute lowest limit you are able to do. If they are refractory or resistant, meaning that there continues to be persistent inflammation or new vascular involvement is happening, then you need to consider the use of biologics. And it's usually anti-TNF agents like either infliximab or adalimumab or anti-IL-6 like tocilizumab that is being used. Leflunomide has also been used in some patients. There is in the trials, and there is some work going on with the use of ustekinumab, Indian pathological background that we have in Takayasu. It has not been found to be very useful. JAK inhibitors, which are probably we are in the era of JAK inhibitors now, they are being tried and perhaps we may find some success with these. The other aspect of management is the interventional aspect, endovascular interventions in surgery. So with this is again a situation where multiple specialists need to be involved in managing the patient appropriately. And these are the current series of patients with childhood Takayasu that are in print at present. I'm very proud to tell you that there are 2 of these series come from India. One of this Goel et al. Is actually Dr. Satish Kumar series, and he's one of the chairpersons of this talk today. And the other one is from SGPGI, Mishra et al. And there is a lot of concordance between many of these series, and it is really, the delay in presentation. Many of these patients, for instance, in the Vellore series, the delay in presentation was found to be around 11 months. And certainly there are patients whom we have seen with probably several years before they are discovered. So there are so many challenges in trying to think about this diagnosis, trying to make it early, trying to assess disease extent, assess disease activity, such that we treat the patient who has disease activity and we do not use immunosuppression of somebody who has completely burnt out, damaged disease. And so also the immunosuppression has to be appropriately aggressive. Certainly the patient should never be treated with steroids alone, and management has to be shared with the rheumatologist and the other specialists, and interventions to be tried to be done during the inactive disease phase. At this point, I'll also pick up the one question that was already asked about mantle positivity in Takayasu disease. It's been a favorite theory that the mycobacterial heat shock proteins and the host heat shock proteins tend to have a cross reactivity, thereby generally showing that patients with Takayasu disease have a higher incidence of mantle positivity compared to the general population. However, when quantiferon was looked at, the incidence of quantiferon gold for TB positivity in comparison to the general population was found to be equal. It all depends on what you're able to do. If you think your patient has latent TB, then you need to, since you're giving immunosuppression, you need to use latent TB management guidelines along with your treatment, along with your immunosuppression. If, however, you think that your patient has active TB, then the patient would need to be treated with ATT as well as the immunosuppression, both of which need to go on, run concurrently. Thank you, and I'll take any questions.
Yeah, thank you, Suma, for your nice lucid talk on management of large vessel vasculitis, including the challenges we have in diagnosis, follow-up, and in the treatment aspect. As we are running late of time, we'll go to the next topic straight away. I am happy to introduce Dr. Kopo. She is a pediatric nephrologist. She is a member of ISN Council and chair of Western Europe Regional ISN Board. She is a co-chair of Scientific of IPNIE Congress in Calgary in 2022. She has got a lot of published several peer-reviewed papers and reviews. She is also a member of IgA Nephritis Network Research Group member since May 2021 and ESPN Glomerular Disease Working Group since September 2020 and various other international leadership roles. She is going to talk on IgA nephritis or HSP. Is it the same? Two sides of the same coin. As Dr. Kopo is not able to join us live, so we will have a recorded session of Dr. Kopo's talk, followed by we have some, if there is a time permits, we'll have some question and answer session also. Thank you.
Dear friends, let's speak about IgA nephropathy and the Hinox-Schönle-Purpur nephritis, different face of the same coins. IgA nephropathy is defined by the detection of IgA in glomeruli as the dominant or codominant immunoglobulins with respect to the others. But these definitions fit with the diagnosis of primary IgA nephropathy, Berger disease, as well as IgA nephropathy secondary to IgA vasculitis or Hinox-Schönle glomerulonephritis. Primary IgA nephropathy is known to have an onset often with gross hematuria following an upper respiratory tract infection, macroscopic hematuria without an associated proteinuria, and the natural history is most common in young adults with relentless progression. In children, there is a possibility of remission and frequent progression over decades. Hinox-Schönle-Purpur is characterized by the presence of diffuse abdominal pain, arthritis, renal involvement, hematuria and proteinuria, but most of all, biopsy samples show a predominant IgA deposition. And indeed, this is a vasculitis with IgA-dominant immune deposits affecting small vessels of skin, gut, glomeruli, with a disease which is similar to IgA nephropathy, which is characterized by the systemic coincidence signs. And the natural history is that the most common in children is the most frequent remission. In rare cases, there is a rapid progression, possible progression over decades. So there are similarities and differences between primary IgA nephropathy and IgA nephropathy related to vasculitis, IgA vasculitis, being in most cases a relentless progressive disease, primary IgA nephropathy, while an acute disease with self-limiting history is characteristic of IgA vasculitis nephritis. And there are differences as well between children and adults. What makes the difference is a different pathogenesis, is a different genetic condition, is different genetic factors. Are two faces of the same coin, is requested by the organizer. IgA nephropathy is a typical product of mucosal immunity. So mucosal immunity plays a first role in the pathogenesis of IgA nephropathies. The first pathogenetic events is represented by the production of galactose-deficient IgA1, deficient in N-acetyl galactosamine and in the short carbohydrate side chains bound in the hinge region of IgA1. These are triggered by infections and induce the production of autoantibodies IgG or IgA against galactose-deficient IgA1, and so the formation of circulating immune complexes and the deposition in the mesangial area where activation of podocytes, besides mesangial cells, endothelial cells, and renal cells, and full development of nephritis. And this hypothesis is valid for IgA nephropathy as well as for IgA vasculitis nephritis. Moreover, the Renato Monteiro group discovered a role for CD-soluble CD89, which is a soluble receptor for IgA1, which forms a macromolecular complex with galactose-deficient IgA1, which facilitate binding to specific receptors expressed on mesangial cells, transferrin receptors and transglutaminase 2, leading to development of mesangiopathy and IgA nephropathy. However, apart from this similar pathogenetical hypothesis for both diseases, there are clinical features which are variable as onset, variable renal regions, variable outcomes, ranging from remission, from indolent course, slow progression, or a rapid progression. What can be the factors modulating the different features of these two diseases? Maybe genetic conditioning. In IgA nephropathy, 3 areas of SNPs were identified related to HLA, complement, lymphomonocyte cell interplay. But it is of interest the variants of the genes involved in galactosylation of IgA1 are associated with genetic susceptibility of IgA nephropathy. For IgA vasculitis nephritis, again, HLA is involved as a genetic conditioning factor, as well as the genes coding for cytokines, chemokines, adhesion molecules, nitric oxide, neoangiogenesis. But of interest, again, an important role is played by genes modulating IgA galactosylation. Are these genetic factors conditioning the circulating factors? Well, the levels of galactose-deficient IgA1 are similar in children with IgA, primary IgA nephropathy or IgA vasculitis nephritis, and are similar also in adults. The serum galactose-deficient IgA1 levels are highly inherited because they are shared with relatives of patients with IgA vasculitis and IgA nephritis. So an important inherited effect is played. In young adults with IgA nephropathy and IgA vasculitis, high level of galactose-deficient IgA1 were detected, but also high levels of IgG directed against galactose-deficient IgA1, particularly in active phases. Very recently, Renato Monteiro's group, Alexandra Cambier, reported the presence of high level of complexes formed by IgA and the CD89 in the serum of children with IgA nephropathy. And this was observed as well in children with IgA nephropathy vasculitis. and as well as in urine, high levels of IgA and interleukin 6 and 8 were reported. However, at multivariate analysis, no effect on disease expression or progression was observed for any of these biomarkers. And this is similar to the reports of our last review on this disease, where we investigated the role of circulating IgA molecules, receptor of IgA1, cytokines, mesenchymal cell receptor, and product of mesenchymal cells, but no difference was found between IgA nephropathy and IgA vasculitis nephritis. So we can think that the pathogenic events are the same, but there is something which is peculiar to IgA vasculitis. IgA vasculitis is a vasculitis, so complement endothelial activation coagulation may play a role. And indeed, there is a higher activation of complement in IgA vasculitis nephritis in comparison to primary IgA nephropathy, detected at serum level and at histological level, as well in the coagulation activation cascade, which is typical of IgA vasculitis nephritis. Recently, deposits of C4d have been found in adult and children with IgA nephropathy and associated with progression. Of interest, there are signs of complement-mediated microangiopathy in IgA nephropathy as well as in IgA vasculitis with nephritis in children and in adults, with co-localization of C4d in microangiopathic lesions. Of interest, the cases showing coincidence of C4d and microangiopathy showed a higher risk of renal replacement therapy. So there is something in glomerular endothelial activation, C4d deposition, microangiopathy, and immunoglobulin in IgA nephropathy, but even more in IgA vasculitis nephritis, where endothelial cells seems to play an important role, as reported in this brilliant review, showing that the TNF-alpha activated by infection can enhance the binding of circulating IgA anti-endothelial cells to the vascular surface, leading to attraction of neutrophils and release of reactive oxygen species and other mediators. And about the other mediators, it is of interest the activation of neutrophil extracellular traps, the nets, the fibrous networks protruding from activated neutrophils, and play a role in bridging inflammation and coagulopathy, which is typical of inoxion and purpura IgA vasculitis. So the involvement of neutrophil extracellular traps in IgA vasculitis has been recently reported in circulation as well as at the glomerular levels, and particularly at disease onset and inactive groups. And this is extremely of interest that IgA and particularly CD89 are triggers of the activation of polymorphonucleates that play a role in induction of NETs. So CD89 may play a particular role in IgA vasculitis by activating of extracellular NETs. The two diseases have similar histological features, but some slight different. There are several histological features which characterize IgA nephropathy, which are risk factors for progression independent from clinical data, renal biopsy during the follow-up. Mesangial hypercellularity, endocapillary hypercellularity, segmental glomerulosclerosis, tubular atrophy, interstitial fibrosis. And we reported that the Oxford classification is similar, is valid in children as well as in adults. And this was reported in several studies from different countries. The Oxford classification is valid in children. But which is the role of crescents? Crescents were found to have a value only in IgA nephropathy, only in cases without immunosuppression, where in adults they were found to have a value as a risk factor in untreated cases, particularly when they involved more than 25% of glomeruli. So crescents were added to the Oxford classification. And the validity of crescents was reported in some of the study from investigated the Oxford classification in IgA nephropathy in children. And for instance, in Japanese children, there was a value for progression factor for children showing more than 30% of glomeruli involved in crescent formation. However, that was valid only at univariate analysis, not a multivariate analysis. And crescentic IgA nephropathy in children were recently reported by Japanese doctors to have an unfavorable role of progression in IgA nephropathy, but anyway, less than what observed in adults. Crescents are particularly crucial in IgA vasculitis nephritis. And indeed, the classification of Venous and Improper IgA vasculitis nephritis by the International Study Kidney Disease in Children was based on the extension of crescents, less than 50% or above 50-75% or above 75% of glomeruli. And in a study of ours some years ago, we investigated in Italy more than 200 patients with IgA vasculitis nephritis. Most of them were divided in two classes, without crescents or with crescents involving less than 50% of glomeruli. And the children and adults, there was no significant difference in survival time to dialysis in crescentic and non-crescentic form, but there was some interaction with age and crescents on renal survivals. This is very difficult to considering the effect of crescents, since crescents are found when biopsy is prompt, may be coincident with acute onset and then disappear, may regress and evolve into sclerotic lesions. So they are a highly dynamic features. It is very important, the timing of renal biopsy. Indeed, as the time from renal biopsy progresses, cellular or fibrotic crescents become more important, chronicity indexes become more important and influence the negative outcome, so as moderate and low-grade proteinuria correlates better with chronic lesions than crescents. So what is the value of MEST score in children? In this meta-analysis, it was reported that in children, the MEST score are valid as a prognostic factor in IgA vasculitis nephritis. However, when focusing on crescents, no predictive value for crescents was found in children. A recent study from Poland reported the value of crescents at univariate analysis being more relevant when the MEST score was more important. But this study from China reported that more than crescents, segmental glomerulosclerosis and most of all tubular atrophy and interstitial fibrosis are relevant factors for progression of IgA vasculitis nephritis. And the group from Matti-Nuutinen in Scandinavia reported that maybe it is more of interest to look at active lesions and chronic lesions, which are not much considered by the Oxford study. And they reported in repeated renal biopsy a reduction in activity index and an increase in chronicity index. But for the best evaluation of prognosis, we have to mix clinical and histological data. And it is important because IgA nephropathy has a variable presentation from clinical point of view, which is particularly important in children in some of these presentation and less consistent forms. In children, the progression is less than in adults, as we reported in the validation study of the Oxford classification. For it is reported IgA vasculitis in children, microscopic hematuria and hematuria non-nephrotic proteinuria or hematuria nephrotic proteinuria and rapidly progressive course are the most frequent clinical presentation, while some of them, only minority, show a persistent microscopic hematuria with decreasing GFR and increasing proteinuria. So in 2-3% of cases with IgA vasculitis, there is a progression to the long-term renal failure during the follow-up, while in most of the cases there is a recovery in 4 weeks, and in about 1/3 of the cases there is a normalization in even a shorter time. So the characteristics of frequent rapid regression of IgA vasculitis nephritis in children. Today, rarely children with IgA vasculitis nephritis reach kidney failure within the pediatric age. However, this disease may have a progression to subclinical damage and can develop chronic kidney damage as well as hypertension. So we have to look at the risk factors for progression, which for adults with IgA nephropathy are typically represented by proteinuria, hypertension, reduced renal function at presentation. For children, the clinical data, renal biopsy, proteinuria, hypertension, reduced GFR are not significant predictor of outcome, while only follow-up time average proteinuria and persistent blood pressure increased values are significant indicator for progression. Children with IgA nephropathy followed for a median of 5 years kept persistent time average proteinuria of more than 1.5 grams per day, which, according to our European study, Valiga, is a risk factor for progression, even if below the classical 1 gram per day, which is considered by KDIGO. Indeed, in our study of a long-term outcome of inoshone nephritis in children and adults, we found that the most relevant factor for progression was the persistence of proteinuria during the follow-up. So it is important to combine the clinical and pathology risk factors. Indeed, the combination, the MEST score and clinical data increased the prognostication of outcome in IgA nephropathy. And basing on a large global collaboration of about 4,000 patients with IgA nephropathy, a prediction tool was assessed to calculate on the basis of age, sex, race, GFR, blood pressure, proteinuria, and prior use of renal angiotensin system or immunosuppression and MEST score, the risk of composite endpoint, 50% decline in GFR or stage renal disease at 5 years, and allow the stratification of patients into different risk, low risk, intermediate risk, high risk, high risk. The same was recently reported in children with another study involving more than 1,000 children with IgA nephropathy, while the adult cohort was characterized by a stable rate of GFR decline, the pediatric cohort was characterized by a trajectory with an initial increase of improvement in renal function, then a stable decline in GFR, similar to adults. So basing on this model, various different risk stratifications were established in children, which allow the identification of patients at risk. The similar is under evaluation for IgA vasculitis nephritis. The international study is ongoing, and the aim is to identify prediction tool for IgA vasculitis nephritis to detect patients with risk of progression. A lot of patients were collected, more than 300 children with 4 continents, and the study is in progress. So IgA vasculitis nephritis is an acute onset, rapid development, and possible regression. After an acute onset, can progress as primary IgA nephropathy with a slowly progressive course, sometimes with new cell activity, while primary IgA nephropathy mostly has a slowly progressive course with a relentless progression to fibrosis. Can you think about 2 faces of the same coin? IgA vasculitis features of acute onset, endothelial cells first target, acute inflammation and crescents. On the other hand, the rapid development, rapid recovery, role of an acute and transient trigger. This is characteristic for IgA vasculitis. Mucosal immunity dysregulation as a background factor, which may be activated by a transient trigger or persist as a chronic pathogenetic mechanism, maintaining IgA deposits and glomerular damage. So, maybe slightly different face of the same coin. Thank you for your attention.
So thank you, Suma, and thank you, Professor Koto, for those two talks. So it was a fabulous clinical session followed by a session on the pathophysiology of two faces of the same coin. So I think we have just one question from Professor Suma, but Dr. Koto is not here. So if any nephrologist would take up the question, that is the prognosis of the patient's post-transplant. So in this patients, what is the prognosis post-transplant? Anyone?
Yeah, so can I answer the question?
Yes, sir, go ahead. Yes.
Okay, so there is a risk of recurrence in the graft after IgA nephropathy patients undergo transplantation, but the risk is small. So IgA nephropathy in the graft on biopsy would be, the recurrence is going to be more common, but graft failure as such because of IgA nephropathy is much less as compared to the other diseases like FSGS and C3 glomerulopathy. So there is no contraindication to renal transplantation when these patients progress to ESRD in these patients. You go ahead with transplant, there is again immunosuppression there post-transplant, yet these patients may develop graft failure because of IgA nephropathy, but that portion is quite small.
Thank you, sir.
Yeah, Priyanka, with your permission, can I have a question?
Yeah, go ahead.
This question to Dr. Tullas or Dr. Pankaj Hari, sir. Basically, like going back to that same question, like, is it different? IgA nephropathy and HSP nephropathy. Clinically, like, have you seen it to be different? Outcomes, have you seen it to be different? Your comment on it. Pankaj sir, Dr. Tullas, in any of them or both of them, maybe both of them. Dr. Tullas?
Dr. Jel, would you like to answer?
Dr. Tullas, are you around? Or maybe Pankaj sir, you can.
So as Dr. Kopo also showed in her slide that the risk of development of ESRD in HSP or IgA vasculitis nephritis is less common, far less common than IgA nephropathy. And that's why when we look at our cohort of children who have undergone transplantation, we don't seem to remember any IgA nephritis that we have transplanted. On the other hand, we have patients of IgA nephropathy who have undergone it, who would transplant and have gone into ESRD. So the risk there is much smaller, and maybe they will be developing CKD much later in life, those who have presentic forms, but you don't see that them going into ESRD in the pediatric age group. Does it answer the question?
Yeah, but so yeah, I mean, from our experience also, we have seen that IgA nephropathy sometimes can present in a very bad way. Organizer, can you please mute the mic? So we have seen like IgA nephropathy most of the time being an indolent course, and HSP nephropathy many a time being more of a severe course. But what is the pathogenesis like? Do we know of a pathogenesis that sort of explains this?
I don't know. Dr. Kopo had some slides which was trying to explain whether there is some difference in the pathogenesis, and that's why IgA nephropathy is more.
But there were supposed to be quite subtle differences. So maybe I can ask Dr. Tullas this if we can hear. Dr. Tullas, can you hear us?
Yeah.
So my question was like, I mean, Dr. Kopo had just had a beautiful talk on whether IgA vasculitis, which we previously used to say HSP thing, and whether IgA nephropathy are different or not. And from our experience also, we have seen their clinical manifestation is often different. HSP nephropathy, they usually have a more intense course, whereas IgA nephropathy usually have an indolent course. Like, is it the same from your experience? And like, any short answer of why they are different?
Well, I was a little bit surprised about the conclusion that we just heard, because I thought that there was a bigger sort of agreement that they are clinically very, very different, and therefore must have a lot of different mechanisms going on, even if I can find similarities. Because it's obvious what you said, that the an HSP nephritis is a very acute disease, which in 99% of cases sort of gets well, while IgA nephropathy is an indolent, slowly progressing in some. So the mechanism behind them doing such a different clinical pattern must be different, and the treatment of something very, very acute to something that takes many years to develop must, of course, be very different. And that there's been in the KDIO guidelines a lot of, one have drawn similarities, and there's been a lot of critique against that you really can't treat them, at least not in the initial half year, a year, totally similarly. I would be interested to hear what Dr. Ovni also says about this. What do you feel, Louise?
I don't know. I get more and more confused, and then get my head straight that they're the same and then they're different. And I don't know. I think in Professor Koppu's talk there was some nice comparisons to do with the endothelium, and I think they're the key differences in the IgA vasculitis compared to IgA nephropathy. But I think there's so much we don't know about IgA vasculitis that it's just hard to conclude, is my thoughts really, that there's a lot more known about IgA nephropathy than there is IgA vasculitis. So I think we're trying to compare things when there's probably more biological information available for one disease compared to the others. I think they're clearly linked, but it's difficult to see how they are exactly the same and whether treatment should be the same. But I think time will tell as we begin to learn more about both diseases, then hopefully we'll be able to see the similarities and differences.
So it is nice to know that it is not only me that I don't know the answer. Good. There was a question, Satish, from Dr. Sushmita Banerjee about, again, Dr. Tullas or Louis can answer, any difference in treatment protocol for IgA nephropathy and HSP nephropathy, and how long would you give the immunosuppressant?
This is one thing that I, in a tiny bit, will discuss during my talk. So I think I will not give the answer yet, but leave it half an hour. It's by no means a totally correct answer, but it's one answer. You will hear it in half an hour.
Thank you. So Satish, it is all yours.
Satish, so I don't think Satish is here.
Yeah. So now we'll move on to the next sessions. Over to moderator to introduce the chairpersons.
So we move on to the last session, and it's my pleasure to welcome the chairpersons for the last session. The first chairperson is Dr. Amitabhadi. He is a very well-known and a very senior pediatric nephrologist. He's been the president of Bengal Society of Pediatric Nephrology, the West Bengal chapter of ISPN. He's a professor in the Division of Pediatric Nephrology at the Institute of Child Health, Kolkata, and he has more than 35 years of experience. The second chairperson is Dr. Narendra Bagri. He's a pediatric nephrologist, a dear colleague of mine, an associate professor at the Division of Pediatric Rheumatology at All India Institute of Medical Sciences, New Delhi. He's a very enthusiastic young pediatric rheumatologist who is involved in several funded projects funded by ICMR and others. The third chairperson is Dr. Himesh Burman. He's an associate professor in the Department of Pediatrics at the Nigrims, Shillong, which is Northeastern Indira Gandhi Regional Institute of Medical Sciences. And last but not the least, the last chairperson is Dr. Mridul Plabon Bora. He's a pediatric nephrologist at the Apollo XL Care Hospital, Guwahati, India. Over to you for the next session.
Yeah, good evening all. And thank you, sir, for the nice introduction. So it's my pleasure to initiate this session, which is in fact I guess is an interesting session entitled Pediatric Rheumatology and Pediatric Nephrologist, a duet or a solo performance, which probably captures the the theme of this scientific deliberation. So to begin with this session, we have two reputed one pediatric nephrologist and one pediatric rheumatologist. And it's my pleasure to introduce Dr. Louis Oni, who is a senior lecturer in pediatric nephrology at Elder Children NHS Hospital, Liverpool. Dr. Oni is the recipient of ERA EDTA Award in 2016, and she is a member of ESPN. She has chaired the nephrology unit in 2006 at Margarita Children's Hospital, Turin, for nearly 1.5 decades. And she carries a vast research experience gained at various prestigious universities like Wayne State University, Detroit, Cass Western University, Cleveland, to name a few. So welcome, Dr. Louis. And so before we begin this session, I would invite my co-chair to introduce next speaker, Dr. Eve Smith, the pediatric rheumatologist. Dr. Mridu, please, can you introduce Dr. Eve? Dr. Mridul, are you around?
I think Dr. Narendra, if you continue to actually introduce Dr. Eve Smith as well, that would be very useful. Fine. Thank you.
So for this session, the pediatric rheumatologist with us is Dr. Eve Smith. She has more than 35 peer-reviewed papers and chapters in various books. And she's a recipient of Arthritis Research Campaign Scholarship, Wellcome Trust Elective Prize, and many other prestigious awards. So with these two eminent speakers, I think this session is going to be interesting. May I invite Dr. Oni to begin with? Yeah, please.
Excellent, thank you. So hopefully the slides are just coming up.
Yeah, it's fine.
Okay, excellent. So yeah, thank you for the introduction. And I think some of the details about my background and chairing departments in Italy were not necessarily that accurate, but still I'm here, and it's really a great pleasure to join this educational event. And myself and my colleague, Dr. Eve Smith, are going to do this presentation as a double act. So we have shared slides, and we'll be speaking interchangeably to present our work today. And this session over the next kind of half an hour is hopefully going to illustrate to everybody how, when pediatric rheumatology and pediatric nephrology work hand in hand together, hopefully we can see improved clinical and research outcomes in our patients. And we're going to frame this around juvenile systemic lupus erythematosus as the example for this. So next slide, please. So just as an outline for our presentation, hopefully we'll be able to describe some of the ways that we work together, both on a clinical basis and then in terms of our research, and showcasing some of the work that's come out of our institution. And then, as I mentioned, we'll be using the example of systemic lupus erythematosus, because it's probably one of the conditions where rheumatology and nephrology are absolutely critical to the management of the care of these patients. And we're going to highlight some of the key points in childhood lupus nephritis, which hopefully will reinforce some of the learning that's been already nicely presented by Dr. Singh earlier, and some clinical case examples just to put things into context. And then we'll finish with some of the ways that we see that research can improve the care and hopefully the outcomes for the future generations of children with lupus. Next slide, please. So myself and Eve are based in Liverpool in the northwest of the United Kingdom, and we work at the same hospital together, and I'm actually involved in the connective tissue diseases clinic. So we do a joint clinic with rheumatology and nephrology in the same room with the patients, and we work extremely closely together, both in terms of seeing our patients in the clinical setting and being able to deal with patients within the ward if they're acutely unwell, or in the longest term during their follow-up period. And we have a relatively large catchment within a tertiary children's hospital where we have tertiary paediatric rheumatology and paediatric nephrology. And our centre is considered a UK centre of excellence for childhood lupus. Next slide, please.
Louise mentioned, hello everyone, my name's Eve Smith. So Louise mentioned that we work together on a clinical basis, but also in research. And this slide really highlights...
Eve, your microphone is a bit silent.
Oh no. Let me get some headphones, sorry. Usually this works fine. Is that better?
Much better.
Much better. Okay. So this slide really highlights some of the research that Louise and I have done together. So we have been interested for quite some time now in urinary biomarkers for lupus nephritis. And Louise, her PhD was around initial identification of biomarkers, and she set up a lot of work that's been going on in the UK looking at initially collecting urine samples, collecting clinical data, setting up a biobank and mechanisms really for longitudinal collection of these samples, looking at individual biomarkers for lupus nephritis initially, and then laying the foundations for some work that I then took on as part of my PhD, looking at panels of urinary biomarkers. So we were able to show that individual biomarkers worked pretty well for identification of lupus nephritis, but actually by combining them in a way that we would normally do when we look at patients, we wouldn't usually just look at one single thing. By combining them together, we were able to get better predictive value for identifying active lupus nephritis. So we did this work initially in the UK along with Chell as well, who's obviously chairing, looking at samples from Great Ormond Street and also from Liverpool. And then we set out to try and validate these findings in samples from Albert Einstein College of Medicine in the States and also from the University of Cape Town in South Africa. And because this panel of biomarkers performed equally, if not better, in these validation cohorts, we then moved on to developing an assay for measuring of all of these at once, a multiplex assay with a company called Multiplex. And at the moment, we've been more recently looking at prediction of treatment response as part of the Adult Master Plans Consortium, looking at prediction of response to rituximab predominantly. So this is an example of where we sort of started working together in research, and this was really foundational in terms of getting us all working together, and lots of projects have led on from that. The other area that we've done a lot of work together in is around trying to improve awareness of both pediatric rheumatic and renal diseases. So I think a number of the talks really highlighted that access to care, detection of these rare conditions is really key, and that if we don't detect them, then obviously the kids can't get the right treatment. So we've done a lot of work as part of World Kidney Day and also as part of World Young Rheumatic Disease Day, Word Day, which is coming up on the 18th of March, trying to push these issues both on a national and an international level, and creating videos and other social media type content that we can use to try and improve awareness of these conditions. Louise.
So I'm sure everybody in this call is aware that juvenile systemic lupus erythematosus is actually a rare autoimmune disease with an incidence of kind of less than 1 per 100,000 children. And we know that about 1/5 of all cases will present during childhood. And there is ethnic variation. We see variation in the incidence and prevalence across the whole world, dependent on ethnicity. And we see a female predominance in the children, but not as striking as what happens in the adults, where the female to male predominance will be 9:1 in adults, whereas it's around about 5:6 in the pediatric setting. So as we know, lupus can have a very wide differential diagnosis that can present with very non-specific features, and that's perhaps where our rheumatology colleagues are expert in trying to identify which features might actually be pathological and which might actually be just be part of an intercurrent illness or some transient feature within that child's phase of life, such as being a teenager. So we know that there are very subtle signs, and we know that there are a number of investigations needed to help with the differential diagnosis of lupus. We also know that the background of lupus is a combination of a genetic susceptibility. There have been a number of genetic studies published now which identify key regulatory factors within an individual that predisposes them to being at risk of genetics. And this genetic susceptibility might be even stronger in the younger patients who present in the younger age group. But we also know that there are environmental triggers. We see this in international cohorts, things like occupational hazards, viruses, UV light exposure. There have been publications on vitamin D deficiency and also on the influence of sex hormones over time. So there are environmental triggers on a background of a very abnormal and unstable dysregulated autoimmune immune system. So we know that there's a combination of triggers for lupus that may change and may be very individual to that patient.
And I think this was mentioned briefly earlier on, but it's important to think about classification criteria in lupus. A lot of people use them as diagnostic criteria, which isn't what they were intended to be. They're primarily meant to be for classification, for making sure that when you do clinical trials in lupus, that the patients that you include are most likely to have lupus and are relatively homogeneous. There's been a number of iterations of classification criteria. So the first ones were the ACR criteria, so 12 criteria, which you can see listed here with their definitions. Following on from that were the SLIC 2012 classification criteria. And these differed from their predecessors in that there was more criteria. So we went from 12 to 11 clinical criteria plus 6 immunological criteria. And importantly, again, you had to have 4 or more criteria, but they had to be spread across the clinical and the immunological categories, with the caveat that actually you could be classified as having lupus with biopsy-proven lupus nephritis and a positive ANA or dsDNA. And it's probably fairly widely accepted that SLIC 2012 criteria are felt to be what we should be using in pediatrics predominantly. So within the SHARE guidelines, they recommend use of SLIC 2012, and most rheumatologists do these days recommend them. More recently, there's the ACR-EULAR criteria. So these are, interestingly, they've been formed predominantly by adult rheumatologists, so there wasn't any pediatric rheumatologists or nephrologists as part of the consensus group forming these criteria. And they have this entry criterion of having to have an ANA of 1 in 80 or more. So if you, according to these criteria, if you're ANA negative, you do not have lupus. And these are additive, and for these criteria, you need to have 10 points or more. And these are the criteria here. And as part of the UK GSLE cohort study, so Louise and I have both done a lot of research as part of the UK GSLE cohort study in the study group, and this is a national group of clinicians interested in lupus from across about 25 sites across the UK, and there's about 500 patients that have been recruited to this study since 2006. And one of the studies that we've done, or 2 of the studies, have been looking at classification criteria. So the first was comparing the ACR 1997 criteria and the SLIC 2012 criteria. And what we found was that the SLIC criteria were more sensitive, both at diagnosis and at last visit. More recently, we've looked at comparing the SLIC criteria and the ACR-EULAR, and again felt that the SLIC criteria were better. The reason for this is shown here, is that actually there are a number of patients that are included in the UK GSLE cohort, particularly the younger patients who are not ANA positive when they're first diagnosed. So they meet other criteria for lupus. They're considered by clinicians who are expert in treating lupus to have lupus. And actually over time, a lot of them go on to develop ANA positivity, but maybe at that initial diagnosis, some of them don't. And if these patients are just immediately sort of know they're definitely not lupus, then it may well lead to delays in treatment and inappropriate management. And this is just some work that's going on at the moment and is actually in press at the moment, looking at genetics of lupus as part of the UK GSLE cohort. And what they've shown is that about 7% of cases had some inborn error of immunity, and these are the patients that are more likely to be ANA negative. So particularly within pediatrics, we feel quite strongly that the EULAR-ACR criteria don't perform quite as well. Thinking about how pediatric and adult lupus differs from one another, then this is some work that we've done, again, as part of the UK GSLE cohort study, but working with the University College London lupus group, comparing patients with childhood onset and adult onset lupus. And they had 924 individuals in total, and they cut them up into different age cutoffs. So less than 12 for childhood onset, 12 to 17 for adolescent, and more than 18 for adult onset. And you can see quite nicely here this difference in male to female distribution that Louise mentioned. So across childhood, it was 6:1, but then when you look at childhood to, the younger ones, it's 5:1, the adolescents it's 7:1, and then the adults it's 13:1. So it changes quite markedly. There was also some differences in terms of ethnicity, with more ethnic minority patients in the childhood group. Then looking in terms of organ manifestations, particularly to this audience, it's very clear that children have more lupus nephritis than adults. So you can see that there's a significant difference between childhood and adolescent, adolescent and adult, and overall there's quite a significant difference there. There's also a trend towards some difference in neurological, so there's a difference between childhood and mature, but not when you compare all children and all adults. The very striking and worrying thing that we saw as part of this study was the difference in the standardized mortality ratio according to age. So what you can see is that in children between the age of 0.0 to 9, the SMR was 87.3, coming right down to, in the oldest age patients down to 1. So the younger you are with lupus, the higher your standardized mortality ratio. And if you compare all children to all adults, there's quite a big difference there. So this is one of the more worrying findings from that paper. And damage is really a predictor of mortality and an indicator of severity, and something that we really need to be preventing. And this is some work that's come out of a collaborative study involving, again, the UK GSLE cohort study, but also PRINTO. So PRINTO is an international organisation from Europe that includes centres from across the world, and also the PRCSG, which is a North American group. And they combined all their patients together and had over 1,000 patients, and were looking at damage as defined by the SLIC SDI, which is a damage score. And what they were able to show was that across all cohorts, children with lupus did have damage, and that there was some differences between the different cohorts. And this was after an average of 3.8 years, so fairly early in the disease. Between 30 and 60% of patients had damage across the cohorts. And the top 4 areas of damage were neurological, renal, musculoskeletal, and skin. So again, highlighting the importance of preventing renal damage. Looking over the longer term, this is the longest long-term study that we have to date. So this is a Dutch study where patients were followed after a median disease duration of 20 years, including 111 patients from the Netherlands. And again, this really highlights, so the third top area of damage was renal. 60% of patients overall had damage in the Netherlands. And the factors which they found within logistic regression models to influence damage were disease duration, whether or not the patients were antiphospholipid antibody positive, or whether or not they had hypertension. So this was looking at a number of different clinical covariates and laboratory markers. So this is all quite interesting, isn't it? That children and adults with lupus seem to differ in many ways. It's often obviously much more severe in children. The outcomes are different. But despite that, we tend to manage them in a very similar way. The treatment options are largely the same. The amount of evidence that we have in children is far less, and there's really an urgent need to try and fill some of these knowledge gaps. And we've only had one drug which has actually been licensed for lupus over the last 50 years, so belimumab. Share's already been mentioned a number of times, but for those who aren't aware of it, so these are consensus-based recommendations underpinned largely by adult evidence because of the dearth of pediatric evidence. But one of the key points that they make is that if there is, in any patients that are flaring, refractory, or you just can't get them off steroids, we need to keep trying to escalate, and we shouldn't be, just leaving people on steroids to try and maintain them.
So I think we'll just try and illustrate that with some case examples, because often that's one of the nice ways to put together some of the evidence base that we've been hearing about. So the first patient example that we've got is a 16-year-old girl who was actually known to have a diagnosis of lupus and was being followed up within our centre. Her initial presentation had involved skin involvement, she had lethargy, she was positive for double-stranded DNA titers, she was ANA positive, and she had a pancytopenia. Her baseline urine tests were actually all normal, and she had a normal renal function, so she had no evidence of any renal involvement at the outset. She was started on MMF and oral prednisolone and hydroxychloroquine, but she admitted to having non-compliance because her initial symptoms had been relatively mild. Most of them involved her immunological markers or her hematological markers, and she didn't feel unwell. So during her follow-up, she had rising antibody titers, she had low lymphocyte counts, she had persistently low C3 and C4, and she had a rising ASR. Despite pediatric psychology involvement, she continued to have non-compliance and just did not believe that there was a condition that could make her unwell. She represented acutely with clinical signs of edema with the swollen ankles and also periorbital edema. She was nephrotic and she had an impaired renal function. Her urine albumin to creatinine ratio was extremely high, so this is several grams of protein lost per day. Her blood serum albumin was low at 19, and her serum creatinine was significantly elevated with acute renal failure. She had anuria and she was fluid overloaded with hypertension with a systolic blood pressure of 145. An urgent renal biopsy was performed, and at the same time she had hemodialysis access inserted. She had to have acutely 3 sessions of hemodialysis over 3 days. And whilst we were waiting for the histology results, she had 3 days of IV methyl prednisolone. Her histology then demonstrated a class 4 lupus nephritis with very acute changes. And she went on to have a course of intravenous cyclophosphamide because she'd previously been on mycophenolate with this history of non-compliance. And thankfully, she actually achieved a very rapid and very complete remission from a renal point of view. She continued, sadly, to be very reluctant to comply with her treatment after her cyclophosphamide had been switched back onto oral therapy, but had been very reluctant to comply with this and had required very close follow-up to help support her because she was just not really that keen on taking regular medications. Okay, so we probably don't need to go through this with the audience here and the previous speakers, but we know that we classify lupus nephritis, and we know that class 4 is the most significant, most proliferative form of lupus nephritis associated with the worst outcomes. We also, interestingly, did a study a number of years ago now where we actually looked at the intra-observer variability of the histological classification with a number of different histopathologists from across the world at Cincinnati Children's Hospital and from centres in the UK. And what we saw was actually there was poor intra-observer variability. So what we did was we asked histopathologists who were experienced in paediatric lupus to report the same biopsies in each of the centres, and we looked at the variability in the reporting. And so therefore, I think if you are concerned about the clinical status of a patient and you're not really sure whether the histology fits with their clinical presentation, then second reporting or reviewing the histology together is often really sensible. So we did see that variability. And I think this adds to the fact that in trials, we often need to think about core or central reporting of histology if it's going to be crucial in the management of patients. Thankfully, there are a number of different lupus nephritis treatment guidelines, and I haven't put the most up-to-date KDIGO glomerulonephritis guidelines on here, but thankfully they all come across with similar treatment regimes, as I'll show on the next slide. So generally patients with class 3 or 4 lupus nephritis, or those that might have a class 5, which is mixed in with 3 or 4, would start with an induction therapy, which would include methylprednisolone, progression to oral prednisolone, and then either mycophenolate or intravenous cyclophosphamide. As Eve mentioned earlier, there is a real push to review patients and act if they don't seem to be going into clinical remission. And we're within the SHARE guidelines, it promotes a review at 3 months as a bit of a cutoff to review whether there's improvement or not. And if there hasn't been any signs of clinical improvement, then looking at optimizing their treatment through either the optimization of their mycophenolate dose or the addition of rituximab at this earlier stage than perhaps would have been performed previously. And then again at 6 months to review again as to whether there's been a partial or complete response, and if not achieved, to consider switching the immunosuppressive treatments or adding rituximab if not previously done, and again at 12 months. So these regular prompts are really just to try and get patients to get that early treatment in a much earlier stage than perhaps would have happened previously, knowing that these patients are at a higher risk of morbidity and mortality, as Eve's presented earlier on. And again, this kind of progression throughout that chart, really to keep reviewing it in a similar manner with class 5 lupus nephritis, to start with mycophenolate, but review them at 6 months. And if things aren't improving, to consider changing to a calcineurin inhibitor or adding in rituximab at this stage. Okay. So we've talked about lots of the treatments, but I think my case really illustrated quite nicely that this is a very challenging disease that often presents in adolescents, and this is a very difficult part of their life. And I think that, you know, we need to bear that in mind, that there are lots of teenage changes, both in their body and their appearance, but also in their educational achievements and peer relationships that may contribute to compliance of medications. And that may change whether you need to use intravenous medications or whether they prefer oral medications. So treating the child as an individual and reviewing the stage of life that they're at is important too. So then our second example is an 8-year-old boy who was a new presentation. He had evidence of a malar rash. He had some constitutional symptoms with fever and lethargy, and he had arthralgia. His investigations confirmed his diagnosis of lupus with a positive double-stranded DNA. He was positive ANA. He had mild anemia. He was lymphopenic, and he had a low C3 and C4 count. His urine and renal function was normal at baseline, similar to our previous patient, and he was started on prednisolone and hydroxychloroquine. Subsequently, over the weeks, he had a persisting proteinuria, very low grade with 1+ of proteinuria, and he had some early morning urine samples sent for his albumin to creatinine ratio. And this was a very low level of proteinuria, showing a urine albumin to creatinine ratio of between 30 to 52 milligrams per millimole of creatinine. So this is less than 0.5 gram of protein lost per day. And I think the question really was should we biopsy this patient? And that's a question that we, as a multidisciplinary team, discussed on several occasions for this patient. Next slide. So we did do the renal biopsy, knowing his background diagnosis, and after a long discussion with the family, we consented them for the risks of a biopsy. But actually, surprisingly, or perhaps not unsurprisingly, if you look at the literature, his biopsy was consistent with a class 4 lupus nephritis with very, very active lesions. And so his treatment was changed to add in mycophenolate, and he continued to have persistent proteinuria and had some trouble with complying with twice daily mycophenolate. We therefore progressed to giving him rituximab in addition to his mycophenolate, and he achieved a complete renal remission. So I think the question came up earlier, really, from the previous talks about when to biopsy. The SHARE guidelines have begun to put together some of the evidence and some of the expert opinion as to when to biopsy. And I think more and more literature is supporting that in patients with lupus, we may biopsy at a much earlier stage than we may do for other forms of glomerulonephritis. And that's because the chances are we're likely to find class 4 or class 3 lupus nephritis in those that have a biopsy. And the SHARE guidelines suggest a level of proteinuria of over 0.5 gram per 24 hours, or urine protein to creatinine ratio of greater than 50 milligrams per micromole in a urine sample. And so our patient was probably just on the borderline of this cutoff threshold as to when to biopsy. And he demonstrated quite nicely that there was a very active disease there that was not really apparent clinically. So when we look at the longer term renal outcomes, I think some of these are presented in the previous slides, so we won't touch on them too much, but we know that in the short term, the renal outcomes for chronic kidney disease are probably relatively low, but we have very little very long-term data looking at 10, 20 years renal outcomes in this group of patients. And when we looked at the UK JSLE cohort study, here you can see on the bottom right-hand graph, we saw that even over a very short period of time, which was only a couple of years, we saw that there was evidence of CKD 2 to 5 in our cohort of patients who'd had biopsy-proven lupus nephritis. So I think we're missing a lot of data in the very long term, but hopefully some of these large cohort studies will follow patients up into that long-term period and we'll begin to get that more information. But there is a risk of chronic kidney disease associated with lupus nephritis, and that includes chronic kidney disease stage 5. And we therefore need to look for better, earlier treatments for this group of patients. There are a number of drugs on the horizon that include biologic agents targeting both B cells and other forms of the immune activation, including complement, interferon, and some of the cytokines. And these are at different stages of development at the moment. And hopefully these will have a role in adjunctive therapy for patients who are either not responding at that early stage or who have evidence of activation within a specific biological pathway at the outset.
Just moving on to some of the next steps and the things that we're doing at the moment really around lupus and trying to improve outcomes. So Target Lupus is a programme of research that's been set up in Liverpool and involves collaborators across the world. And this is all around trying to develop a treat to target study for children with lupus. So many of you are probably aware of the concept of treat to target, where you set a predefined target and try and work towards that. You measure it each time you see the patient, and if patients aren't making adequate progress, then you need to escalate treatment with the aim of trying to achieve that target. Once you have achieved the target, then you keep assessing for it at every clinical encounter. And if they lose control of that target, then you do something to try and get them back into the target. So the aim is for tight control, keeping them within target for as long as possible to try and improve long-term outcomes. And this is a concept that's already used in adult rheumatoid arthritis. So any RA patient from day one will be treated to target. It's something that's used in hypertension, I suppose, targeting the blood pressure, and diabetes, we're targeting the HbA1c, and it's coming through in more and more diseases. So we're seeing it in things like ulcerative colitis, psoriatic arthritis, various different conditions. And there's been a lot of interest in trying to develop this approach for lupus, where we know that new treatments aren't really coming out very quickly. So we want to use what we have got in a much more sensible manner. And we have some evidence to suggest that this could be a good approach in children. So we've done one study looking at children who are part of the UK JSLE cohort study and applying targets that have initially been derived in adult lupus. One is low disease activity state, where the patients are in a low disease activity state, but not perfect. They're allowed to be on up to 7.5 milligrams of prednisolone, stable doses of immunosuppression, and they can have positive serology like low complement or high dsDNA, but as long as their total SLEDAI disease activity score isn't more than 4. And looking at patients who achieve that low disease activity state target, it really significantly reduces the risk of subsequent flare and also of damage. And these are two key things that we really want to try and prevent in children. The other thing that achieving low disease activity state seems to do from our data is that it reduces the risk of new damage. We've also looked at clinical remission definitions, adult clinical remission definitions, and these show very similar things to the low disease activity state. And there's quite a lot of overlap between these different definitions. But overall, they point towards that this could be a promising approach. We've also done a national study, which was a qualitative study. So we did interviews with families across the UK, asking them about this idea of treat to target, what they think targets should be, whether or not they think this is a good idea. We've asked them about, disease activity targets and what that could include, but also broader targets, so targeting steroids, targeting fatigue, health-related quality of life. And overall, they were very positive about this idea and this approach, with some of them saying that if they were approached about a study like this, they wouldn't want to be randomized, they just want to be treated to target, which is a bit, early on to say. But overall, there was a lot of enthusiasm for this from patients and families. We've been doing some parallel translational work looking at alpha interferon levels in kids with lupus and in comparison to kids with GIA and healthy controls. So interferon's known to be one of the big players in the pathogenesis of lupus. And previously, we were only able to look at interferon in terms of an interferon signature, which it can be a bit tricky and different people use different signatures. But there's a fairly new assay which is able to look at interferon alpha levels, so actual levels of the protein, because it's a very sensitive assay. And we've been able to demonstrate that the levels of this differ if you're in low disease activity state, if you're in remission, or if you're in active disease. So this might be an interesting biomarker to look at within a treat to target study. We've developed a PPI group, so a public patient involvement group. So a group of patients with two sort of patient ambassadors in particular, who are going to really help us develop the clinical trial and make sure that we're taking into account the views of patients. And on the back of these data and our interest in it, we put out an international call asking people to join a Treat to Target International Task Force. So this call went out in July of last year to members of the Pediatric Rheumatology European Society, to CARA, the North American group, the UK GSLE study group, the UK British Association for Pediatric Nephrology, and some adult rheumatologists who are interested in treat to target and lupus. And we had a huge number of applicants, and there was a lot of enthusiasm for this. And since then, we've come together on 2 occasions, November last year and January this year, to help develop principles and recommendations for treat to target and lupus, and then to think about targets, low disease activity and remission targets for lupus as well. And in the future, we'll be working towards thinking about aspects of the clinical trial. So it's quite exciting, and it seems to be moving fairly quickly. So hopefully this is something that we'll be able to develop a clinical trial over the next few years. So I think what we've shown over the last half hour is that children and adults with lupus are definitely different, that it's very severe. There's a lot of risk of damage, flare, and particularly the kidneys are so important in all this, and that we haven't had any big breakthrough treatments. Belimumab is good, is something to add to our armamentarium of treatment, but using what we've already got in a much more targeted way could help quite a lot in this condition. Thank you very much for listening.
Thank you for an excellent presentation, Dr. Oli and Dr. Smith. The cases you shared and the way you made this collaborative duet presentation, that made it very clear. The answer is very clearly given, that the collaboration between the pediatric nephrologist and pediatric rheumatologist is very, very important. I think there are 2 quick questions that is in the chat box. One from Dr. Bagri. What is the pulse steroid regime do you follow, and how long to continue steroid? And another one from Dr. Subal. How are you managing refractory lupus nephritis not responding to rituximab and cyclophosphamide?
Excellent. So yeah, thanks for the questions. I think steroids is a really big topic that we probably could have spent another half an hour talking about, but ideally we want children to have as little steroids as low as possible, but that's not necessarily always easy in this condition. So for the pulse steroid regime, it's usually very high dose of 30 milligram per kilo with a maximum of 1 gram, ideally for 3 days, but we have had some patients where we'll treat them for 5 days if we feel that they really acutely need that. They will then progress to oral prednisolone or prednisone, and ideally we'd want them to be on a low dose, so less than kind of half a milligram per kilo by 6 months. But a lot of the tapering can be very, very varied. And I think that's where some of the more recent guidelines are trying to standardize even how we taper steroids in patients. And I know in some of the drug trials that are coming through for adolescent and also for adult lupus, they do standardize the tapering of steroids. And I think that keeping steroids in mind, that we want to get the patients off them, and we do have other drugs that we can think about using rather than steroids, is really important. And that's where that regular review period comes into it, really, that we need to be tapering and actively lowering the steroids and thinking about the other agents that we might be able to use for immunosuppressives.
Okay, thank you. So we'll move on to the next topic.
Himesh, can I have just one question?
Yep.
Quick short.
That 30 milligram per kg seems to be quite a high dose of steroid, keeping in mind the recent guidelines. Any comment on like going down on the steroid, and if they relapse, then go for rituximab, or like a B cell inhibitor, something like that?
Yeah, there's so much we don't know about steroids. We don't know if a smaller dose would work as well, and it may do. I think anything between 15 to 30 milligrams per kilo are generally what people are using clinically, but ideally we need better agents, and we need more studies to allow us to look at the more steroid limited or steroid free regimes. And I know that in adults they've tried to do this with some of the steroid free regimes and using rituximab early, and I think that is excellent. I think that is the way we need to be going, but we also do need to bear in mind that increased morbidity and mortality that we see in children, and often the patients will be presenting very acutely, which is quite different to the adults.
So, Louisa, Himesh will get very angry with me, but just one more point.
Yeah, we are really running short of time. Yes.
So keeping that in mind, that lack of studies, so do you use MMF or cyclophosphamide? And how do you choose between them for induction?
Yeah, I think we haven't included that because of time, but we have looked at in a nice paper that even the group have done, looking at the differences between MMF and cyclophosphamide in the UK JSLE cohort, and we didn't see any clinical differences. So I think although a lot of the guidelines say that you can use either, we tend to try and use MMF first as first line. But I do think you need to optimize the dose and get the dose sufficient in patients to see that improvement, and it's also not quick improvement, whereas steroids we know will work fairly promptly. So I think there's probably a role for another agent to be added at an early stage to allow us to get steroids removed, but obviously those studies haven't been done yet, and we await further studies to see what the role is of early intervention, really, particularly B-cell depletion, either with rituximab or some of the other new agents coming out onto the market at that earlier time point, to allow us to become steroid free or reduced fairly quickly. But it's
Can I do a quick comment on this, Himesh?
Yes, please, sir.
We are much harder actually on steroids at Great Ormond Street. We start with 1 milligram per kilo, maximum 30 milligrams at onset dose, because we both see the side effects, and they are so huge. So I think they are a major part of the non-compliance we see. So I think we get a better result with lower steroids. So by 6 months, I think it, to me, would be a disappointment if I wasn't down to 5 milligrams of PRED every other day.
Yeah, I think that's, children hate steroids and there are long-term side effects. We need to be pushing for that. Yeah.
Yeah, thank you. So in interest of time, we would have loved to continue this, but in interest of time, we'll move on to the next talk. So I'll invite Amitabhadi sir to conduct the next session.
Yeah, it's actually a pleasure to introduce Dr. Cheltulus, who actually doesn't need any introduction. I had the privilege of working with him for a few months as a renal registrar in Great Ormond Street Hospital when he first joined, when Prof. Mike Dillon retired. And it was really privilege always to actually hear him talking about one of his favorite subjects, the childhood vasculitis. Dr. Toulouse, it's all yours. Thanks a lot.
Thank you so much. I actually think that I've been given the most difficult topic here. One could talk about this for days, of course, research gaps in childhood vasculitis, because there are obviously so many. But I would try to highlight a few that I think are extra important. I will not go into this because we've discussed that. I will divide my talk into 3 different diagnoses. I could have done several more diagnoses, but that wouldn't be really in the interest of time. So I'm going to first speak about ANCA-positive vasculitis, and we have very well heard about that in a good way, so I'll skip this slide too. Before I start, I would like to share a study that we did quite recently, where we internationally collected 344 children with ANCA nephritis. Just very briefly, you can see here, MPA was the largest, GPA was second largest, and then renal limited vasculitis was actually quite a big group, much bigger than I had expected. And then, of course, some were not classifiable. Very, very briefly, how did these centers treat these children? Well, as induction treatment, they were giving steroids, of course. They were giving mainly cyclophosphamide, but also Betux, a little bit of MMF, etc. So very much taken, of course, from adult data. As you know, there are no solid pediatric data. Maintenance treatment, the biggest one, despite what the data actually should tell us, is MMF. Azathioprine comes first on second place, and rituximab as maintenance. Okay, let me show you the most interesting slide in this, I think. How was the short to medium term outcome of these children? And what you can see is that a vast group here had some kind of need for end-stage treatment. It's 45% of children that either died, they were few, needed hemodialysis, peritoneal dialysis, or a kidney transplant. And we obviously, who've seen these children, know that it's a horrible disease, that these children are very unwell. But I think this very large group of children very much emphasizes that we are in many ways far from good treatment, good enough treatment for ANCA vasculitis. A few other slides. Actually, the boys did better than the girls. If you had an MPA, you did worse than the other types. And you will later, when the publication comes out, see more data. So what do I want to say with this? Well, what I want to say is that we really need to change the fact that children and young people have not been included in any scientific studies in this yet. There's a great need for that. There's been many reasons against it, I can see. One is, of course, that one don't want to try toxic drugs in children, but with this kind of prognosis I show you, I think that's not fully relevant as an argument. And also, of course, people think that there are not many enough, but we managed to, in just a few months, collect 350 kids. So they exist out there, and we can do the studies if we are just allowed and get the money. And obviously, you know that Avacopan is the new kid on the block, where we hope that we will perhaps get a bit better prognosis, but also perhaps more importantly, that we will be able to use much less steroids. And there are studies now on the run for Avacopan in children, and they are really also important. So these are my most urgent research questions. Studies, proper studies to define treatment in children, and proper studies to define role avacopan in children. As you can see, I'm really rushing through this because I was going to talk about two other conditions. One of them is what I personally prefer to call HSP nephritis, because we call the condition HSP, but what is now mainly called IgA vasculitis. Also here, we have actually managed to collect quite a good sample. We have collected 1,100 data on 1,175 children from 42 international centers on biopsy-proven IgA vasculitis. These are how they looked at onset. A very small group, as you know, 3.5% had really low eGFR as onset. Virtually all had proteinuria. Half of them had nephrotic range proteinuria. This is, of course, what we see every day. It is initially, in most of them, not a very severe disease. We don't have a very long follow-up, but it's still a median follow-up of 3.7 years. At that time, more than half of them were totally normalized, and 40% had mild impairment of the kidney function, meaning normal kidney function with proteinuria, or mild impairment of the GFR. A small group, 5%, had significant impairment of the kidney function. And actually, in contrast to what Rosanna Coppo told us, we could, in this huge study, show that low kidney function, low eGFR, low serum albumin, and nephrotic syndrome, thus renal parameters, all the renal parameters that really matter, at what they were at onset were good predictors of worse outcome, which could be a little bit helpful because, we don't know exactly how we treat them. Interestingly, and we are analyzing this further, we did not see that those who were treated with any specific drug, with MMF or a CNI or another drug or no drug, we could not see any difference in outcome. And we need to analyze that further before it is published. And as you know, there are a number of trials with failed treatments, or not very good trials, but failed treatment trials. A case series in IgA vasculitis that suggests benefit. But what are, as I see it, the most important research topics in IgA vasculitis with nephritis? Well, the most important one is which treatment should we use? Is there any of them that actually works? And so far, which? And the topic that Rosanna Coppo discussed, I think, is also really important because there are more studies in IgA nephropathy. And can we extrapolate data from IgA nephropathy into IgA vasculitis, or can we not? My provisional opinion, as you heard, is that we can't. But I think there is more work and studies needed to be done on that. I rush further, and I go to Takayasu arteritis, where we had, I think, an excellent overview that we heard today. I very much agree on everything that was said, but there are many things otherwise with Takayasu arteritis that I feel question marks about. Let us see it from the nephrologist's perspective. And the nephrologist's perspective on Takayasu is mainly renal vascular hypertension, which is an uncommon but existing cause of secondary hypertension in children. There are two easy to diagnose and a few more causes for renal vascular hypertension, and that is NF1 and Williams syndrome. But after taking away those syndromatic ones, there are still about 70-75% of cases left. And they are either regarded to have fibromuscular dysplasia or Takayasu arthritis. And those two are, of course, really different conditions. And what's really important is that there is a huge difference between where in the world the child is diagnosed and the diagnosis it gets. If it's Europe, in some ways in Turkey, but they're a little bit in between, and in the US, virtually all of them are called fibromuscular dysplasia, and a small minority are called TA. As you know, because we are in India now, in India, a vast majority of these children would be called Takayasu, 31 compared to 4, 11 compared to 2, and also the same pattern would be seen in South Africa. And the huge question to me is that true? Are these diagnoses really different in these parts of the world? Or are we more seeing differences in diagnostic traditions? And to be very controversial, perhaps, I think is actually the latter. And if you look at the diagnostic criteria for Takayasu, or they are not diagnostic, but they are used as diagnostic, as everyone knows, but they are called classification criteria. You can, in the newest ones, also put on some kind of inflammatory marker. But if you look at these criteria for Takayasu, every child that we call fibromuscular dysplasia, all of the 150 we have that I've seen over the last 20 years at Great Ormond Street would fulfill the diagnosis of Takayasu. They all have raised blood pressure. They all have, well, hypertension, which is not too far from raised blood pressure. They have decreased pulses sometimes. They have a blood pressure, they have bruise, if you listen. And you have angiographic abnormalities. So these criteria that exist, they're actually not helpful enough. Let me show you how these can affect. This is a published child in Pediatric Nephrology 2009. Came to hospital at 16 months of age, weight loss, abdominal bruising, severe hypertension, impaired kidney function, mildly raised ESR, severe proteinuria, left ventricular hypertrophy. This child would, in our setting, be called FMD. But in this paper, this child was called Takayasu. And the child was very appropriately treated with antihypertensives, but also which we would not have done given steroids, cyclophosphamide, and MMF. And what happened? Well, the child also had mid-aortic syndrome and bilateral renal artery stenosis. As you know, the anti-inflammatory treatment doesn't really cure the vascular lesions because after the inflammation, they continue to fibrose. So even in true cases of Takayasu, I really believe that they exist. And the ones that Dr. Bala showed, I really believe were true cases. But even when you treat them successfully, you should never expect the vascular lesions to go away on their own. But you must, just like Dr. Bala said, you must find the right time to do angioplasty and possibly surgery. In this paper, they didn't dare to do that because they felt this is a vasculitis. And after 2 years, this child's right kidney started to shrink away. So how do you differentiate FMD and Takayasu? Well, you need to look for symptoms or signs of inflammation. And I like to have some diagnostic proof that the aortic or any other blood vessel wall is involved, which could be a thickened aortic wall, or, which is an expensive, complicated investigation, I realize that, a PET scan, where, for example, here, you can see it lights up in the aorta, which of course is very much diagnostic of inflammation in the aorta. So does it really matter? One could ask if we call it FMD or Takayasu. Yes, it does, because it will, of course, decide if he gets immunosuppression. And if you call one of my FMD kids Takayasu, then that child would get immunosuppression unnecessary. But otherwise, it doesn't matter, because you need to do the same surgical intervention procedure. But you should, of course, wait until the inflammation is treated as much as you can, and so that you have a better, it's less risky, and the outcome of the angioplasty is much better. So, what's the most important research topic here? Sorry. Well, as I see it, it is to differentiate Takayasu arthritis from fibromuscular dysplasia. Thank you so much.
Thanks a lot, Dr. Toulouse, for this wonderful talk on the research gap in vasculitis. I think you have actually raised a few pertinent questions that we really ask our other faculties and the moderators to ask any questions.
I think question number 2 and 1 were, of course, not very controversial. Number 3 was much more controversial, of course, and it would be very, very interesting to hear from colleagues in India, which you, of course, all are, what your opinions are on this differential diagnosis.
Parita, Dr. Pankaj Jhari, yeah. Yes, sir. So I think Pankaj Jhari sir will be the best person to answer this, because I don't know why, but at ICH Kolkata, we in the last I've been here say from 2010-11, I remember encountering only 2 or 3 cases of Takayasu from the nephro side with the hypertension. So
at our place, I think largely it depends on the angiographic features, and that the radiologist, if they figure out that whether this could be Takayasu's arthritis versus FMD. Very often we do see some markers of inflammation, particularly on the MR angio or CT angio, in terms of wall edema, that goes more in favor of Takayasu's arthritis rather than fibromuscular dysplasia. But we don't seem to be making the diagnosis of mid-aortic syndrome. We either classify them into, Takayasu's arthritis or FMD. So that's the way we're handling it. I do agree that there is, a clear differentiation sometimes is not possible, and there should be more classification criteria there as to how to differentiate FMD, as you highlighted. Yes. So it's an issue sometimes.
So, Parida, with your permission, if I can ask
please,
one more
please
question.
go ahead. Yeah, please go ahead, Raji.
This is a question by Dr. Susmita Banerjee. Chair knows her quite well. So she had to leave the...
I think she's an excellent doctor.
She has to leave the meeting for another work, but she had WhatsApp me to ask you again about that IgA nephropathy and HSP nephropathy, and how do you treat them, and the duration of steroid.
I think not just duration of steroid. If you are using MMF with it, how long we should continue that, Dr. Toulouse?
Well, I think Dr. Oni also should answer on this, but my very true answer from my point of view is that we have no clue. My gut feel, and of course, if they are severe, I never dare not to treat them. If you have a child that you have given a biopsy and has impaired kidney function, and you have massive proteinuria, it's very difficult, I think, not to give an immunosuppressive agent. So very often we do that. We try to delay it a number of weeks to say that the first 1-2 months things improve so often we don't biopsy. But when we come to that biopsy, and then of course when we do that, a majority improve. My gut feeling, not proved, is that is part of the natural progression. And those very few that we've seen that's gone on to end stage, we've hammered them with every drug and they have not responded. So there is clearly a group that is to me, and that means giving them both the CNI, MMF, and rituximab, which is of course really hammering them. And we have had 2 in the last few years. So I really think we don't know. That is my only honest answer.
So
Louise, you're normally more optimistic than I am.
I think Louise has left. She messaged me that she had to leave for some other commitment. So the KDIGO guideline, if I remember, says that you should first try antiproteinuric for, if I'm not wrong, about 3 months or 6 months, and then if it is not improving, then add further immunosuppressant. So I usually am very hesitant to follow that. What about you?
I think that very few pediatric nephrologists would follow that.
Yes.
Because it's such in those really active cases, they have a very active glomerulonephritis. But it would be lovely if we could find a group who thinks it's good to follow them like that, so then we could do a prospective study. But I think that in the UK, we wouldn't get that through the ethical committee. But that's my feeling.
So is there any pediatric guideline? Because whenever we try to manage these cases, and particularly in current world where like even lay people are getting access to guideline, I'm quite worried about asking that why are you hammering my child with immunosuppression?
Well, I'm very, very open with what I do. I tell them that I very clearly tell them that I'm worried about your child's kidneys because the kidney function is off and there is massive proteinuria. I tell them that I know that many of these will respond on their own without treatment, and that I really have no clear knowledge about how to treat them. But I think if some pushes for treatment, I think the parents in the UK would, in that situation, push equally much for treatment than I do, because they are like me. And they, of course, read me and the rest of the staff to see that everyone is worried about that kidney. And
sorry, and answering that question, like how long would you go on treating them? Like, well, suppose someone has responded well, so how long would you go on with the MMF?
Well, that is also difficult, but I would, with a very good response, I would try to wean out the treatment rather quickly. It's perhaps more difficult if they don't respond, but I guess more than 3 and maximum 6 months without response to a treatment should never be reasonable, should it? But I'm sure you need to give them 3 months to know that it had a chance.
No, suppose if they respond and then now we have weaned off the steroid. So for example, in lupus, we are always worried to stop MMF. What about this HSP or IgA? Like, do you continue on the MMF for a couple of years, 2-3 years, or do you stop it earlier?
Well, lupus is a disease that relapses or gets flares all the time. So that's very true. I think if you have had 3 or even up to 6 months without relapsing, HSP nephritis, I think there are very few that will be relapsing after that. We see those cases. We see those that come back after 7 years and have a new episode. I mean, they are unusual. We can't treat because of them.
Thank you.
So Rajiv, to answer your question that I mean, there are no pediatric guidelines. So IPNA has already a proposal wherein they are going to make guidelines for IgA nephropathy, because it was viewed that pediatric nephrologists view the KDIGO guidelines very differently and they don't follow them. Rightly so, because we don't want to wait for that long to miss the renal inflammation there, and then and that patient going into
keeping them within
failure.
target for as long as possible to try and improve long-term outcomes.
Soon, I think the work groups are going to be formed, and Rosanna Copo is also there in that committee, and then perhaps we will have maybe in a year or two some kind of a guideline. May not be based on the evidence on the adult trials, will have to be more of consensus, because we don't have very many pediatric IgA nephropathy trials. And Koichi Nakanishi from Japan will also be there, because they see more IgA nephropathy in Japan. Yes.
All of us will be.
They are asymptomatic. The Japanese kids are asymptomatic because they are found in the school screening.
Yes, that is different.
Yes, some of our patients are actually different. Often they come with multi-system involvement along with classical IgA vascular nephritis. Like recently, I had a child who had intestinal perforation, needed colostomy, subsequently colostomy repair with a positive proliferative glomerulonephritis with evidence of crescents. So we had to actually treat that child very aggressively. Now, fortunately, that child went into remission of steroids now, still on MMF, and I'm not sure for that individual's patient how long I should be continuing that. Dr. Toulouse, please.
Well, if the child has become totally well and you see no more inflammation, then I'm in this particular condition not so afraid to start to wean the MMF or whatever you have been giving. Because I think this condition will not, if it would have been ANCA or lupus, I would have continued for 2, 3, whatever years or 4 years. I mean, that's so different, isn't it?
Yeah. Thank you.
But I think we also now in this discussion actually have given a quite unanimous answer to the question, is IgA nephropathy and IgA vasculitis the same? We clearly think it's not, because we don't dare use the guidelines that are there, and that's an answer, isn't it? That we don't dare to use the guidelines that were made for IgA nephropathy. We don't dare to use them because we think it's dangerous for our children, and I think that is an answer that there are two different conditions. They might have many similarities, but we don't dare to use the treatment that's been outlined for it.
Thank you. Look forward to a guideline. Yeah.
Well, the SHARE group did guidelines, and they were much more sort of prescriptive in their first versions, but they didn't get them published because everyone's pointed out there is no evidence. So now they have published guidelines, and all 16 out of 17 points in that guideline falls under the category expert opinion. So that's of course also an answer that there is no answer.
Understand. Yeah, I think with the permission of the organizers, because of the time constraint and other things, I'd really like to thank Dr. Toulouse, Dr. Hari, and all the other faculties who really actually made this last session on research gap in childhood vasculitis to so much more enriching for all of us. Thank you very much. Back to the organizers for the next session, and vote of thanks. Thank you. Thank you, Dr. Toulouse.
Thank you.
Yeah. So now time for wrap it up. Thank you, Dr. Toulouse, for your presentation, joining with us from the beginning. Thanks, Dr. Oni, Dr. Smith, and Dr. Kopo, all our national faculty, Dr. Susan, Dr. Hari, all esteemed faculties, all the participants for joining with us for this our 5th annual meet. I also would like to acknowledge to the whole Emcure team for supporting us to organize this CME. Once again, thank you all, and we hope to meet you again some point of time after the pandemic is over and during the world crisis. So with this, let's hope the peace prevail. Thank you all.
Thank you. Bye-bye.
Thank you.
Thank you.
Bye.
Thank you.
Recording stopped.
सर स्ट्रीमिंग बंद कर दो ना